All right, my name is Ethel Rasmussen. It is indeed my pleasure to welcome you to day 2 of the Baltimore County Department of Aging's Senior Solutions Conference. Our mission is strong and strengthening lives by providing services, programs, and connections to resources. We hope to empower each of you to better serve your clients, members, and customers. BCDA offers many options to connect with our programs and services. Please remember to share with your clients and colleagues the many ways you can remain connected with us, such as our county government website, Facebook, the Time of Your Life Digest, community resources, the Time of Your Life TV show on Channel 25 on Comcast, BCDA's 20 senior centers offering virtual and in-person programming. We also have began a YouTube channel for on-demand programming and educational presentations. If you have any questions about that, you can please give our office a call at 410-887-2002. Today's conference will provide further details on the importance of balance for optimal aging, whether that be physical balance to prevent falls or equity balance in service delivery. Over our 2 days of training, we will provide a variety of topics relating to balance. Our BCDA Senior Solutions Conference strives to stay in touch with the changing world and environment in which we live and work and provide tools for each of you to empower your clients and connections to living longer, living well. Thank you also to our wonderful speakers for supporting today's event, along with my talented group of coworkers in the communications office for planning and supporting this training today. Before we begin, I would like to review a few housekeeping remarks. In regard to CEU credits, for the conference will offer 6½ CEU credits for social workers for the 2 days of attendance and engagement. Please note that you must remain actively connected and respond to the various poll questions in a timely manner for the entire day to receive full credit. Thus, make sure you are paying attention for the polling boxes to pop up. Our system will automatically track your engagement with the computer during the day and provide a report of watched minutes. Attendance will also be noted by the poll questions and evaluation at the conclusion of each day of our conferences. Questions during the conference. Please remember to use the chat option. You may direct your questions to the host so that they are not shared with the entire audience list, and you will not be able to speak through this program, so written communication is key. Completion of the evaluation. At the end of the day, we will share a link for the survey. Please go and sign in. If you are looking for CEUs, you will need to put your name at the end of the survey. If you're having any technical issues, you can contact my team at 410-887-2002 or email sponsor BCDA at baltimorecountymd.gov. The PowerPoints, hopefully you received them yesterday in an email. If you did not, you can feel free to contact our office and we can resend it to you. Once again, I want to note that the last presenter's PowerPoint link is in the chat because we received it late to send to you. CEU certificates will be emailed once the attendance has been verified by all of the platforms that I've indicated. Now let's begin our exciting day of training. A month ago, the news was filled with the information that former U.S. Senator Joe Lieberman had died following complications from a fall at the age of 82. Across the United States, falls are an expensive and alarmingly common injury, according to the Centers for Disease Control and Prevention. Falls are also associated with approximately $50 billion of medical costs each year. Further, falls may also raise equity concerns for older adults related to the ability to access acute care in the hospital and to afford aftercare when they want to go home. Our keynote speaker for today will address fall prevention. Dr. Addison has a strong background as a physical therapist and extensive experience in the mobility assessment of older adults with chronic health conditions. As a doctoral student at the University of Utah, she investigated the effects of muscle composition, fatty infiltrate in muscle, on muscle inflammation and mobility function in older, frail adults. Her dissertation findings noted that older adults with increased fatty infiltration also experienced increased inflammatory levels and decreased mobility function. As a National Institute of Health postdoctoral fellow in the Division of Gerontology and Geriatric Medicine at University of Maryland, Baltimore School of Medicine, working in the Baltimore VA Geriatric Research, Education, and Clinical Center. She was actively engaged in studies examining the role of muscle fat infiltration in mobility and balance dysfunction in older adults, including the role of fatty infiltration in the hip abductor muscles on balance in older adults. Her work and postdoctorate led her to the use of peripheral arterial disease as a model of vascular and muscular aging and disability. In her current funded VA CDA 2 grant, she is examining the effects of weight loss, exercise versus exercise alone on improving mobility in older veterans with PAD and the muscle mechanism by which this improvement occurs. For this session, I ask you to consider that falls are the leading cause of hospitalization and death for older adults. We will discover screening tools for fall prevention, as well as evidence-based recommendations for improving balance and mobility and preventing falls in older adults. You will be increasing your case management toolbox with easy to implement tools presented with practical recommendations. It's my pleasure to welcome Dr. Odessa Addison for Balance in Aging, Empowering Older Adults Through Fall Prevention.
Thank you, Ethel, for that introduction. So like it was said, I am a physical therapist by background. I am also a researcher in the VA, and I'm the director of a small falls and balance clinic that we run here in the VA that focuses on veterans that are at high risk for falls and that also have a lot of comorbid conditions. And so that's really the lens that I'm coming to talk to you today about this. And what I'm hoping is that by the end, you'll be able to have some really kind of practical tools in your toolbox. Some you may know about, some you may not, that you can potentially use with your clients, patients, et cetera, to try and help prevent falls. So what we're going to do today is describe some of the screening tools for fall prevention, talk about some of the evidence-based recommendations, and then also hopefully give you some very practical recommendations for this. So whenever I am talking to a group, one of the things that I like to acknowledge are no matter what we do, right, aging is going to be an inevitable process that occurs. And so this is Professor John Turner. He was a psychology professor, and this was actually from a book that was published called Growing Old is Not for Sissies. And the reason that I love this image of John Turner is when you look at it, what you can see is on this side, he's 67, on this side, he's 79. He's obviously somebody who has good genetics, has taken care of himself, is very active, has been exercising. And despite all those facts, he's also somebody that we can notice some changes that are taking place with aging. So if you were to look at him when he's 79 compared to 67, you may notice that his waist is a little bit wider. He has a little less muscle definition, meaning that he's probably lost some muscle mass. He's probably gained some fat in his abdomen. Some of these changes are going to take place no matter what we do. But when we think about aging and fall prevention, what we really want to talk about is what do we do that we can do? How do we make a difference for older adults no matter what stage they're at? So I always like to think about aging in this idea of being this kind of these graphs. And if we think of frailty as being kind of that last stop in mobility or being able to move before somebody dies, then we kind of think of three different trajectories. So if somebody is on this successful aging trajectory, they have good genetics, they've had good access to medicine their whole life, they've eaten well, they've taken care of themselves, they've been exercising, and there's been some luck in that, then they may never actually reach that frailty line. Now, what happens for most of us is that we may have a couple of different chronic conditions. Maybe we are not exercising as much, we're not always taking care of ourselves, maybe there's some genetic things. Then we may reach that frailty continuum earlier, but it's still kind of, excuse me, near the end of our life. However, with chronic diseases, if you have been in situations where you didn't have access to healthcare, maybe you didn't have a great built environment around you, you didn't have good social support, and you add to that, maybe you didn't have access to exercise, to good nutrition, then what potentially happens is we reach that frailty continuum much earlier in our life. And there's a lot of things that kind of contribute to that frailty continuum. Among them are balance and falls. So if you were to ask yourself, what is balance? If you just think for a minute, what do we mean when we say somebody has good balance or somebody has poor balance? What are we thinking of? A lot of us would be thinking about this, right? That balance is really this idea of a gymnast or doing yoga or walking on a tightrope. But what I want to say is that balance is really going to be more than that. So balance is how we're functioning in our everyday life, and it looks much more like this. And so for all of us, and our older adults included, really what it is it's being able to go up and down the stairs and carry your laundry. It's being able to put your shoes on or your pants on without falling. It's being able to do your hobbies and enjoy walking the dog or playing with the grandkids at the beach. Being able to get in and out of the car. These are all going to be very important things. And so when I'm talking to an older adult about their risk for falls, trying to encourage them to exercise, asking about falls, these are the things that I'm keeping in mind. I'm trying to get back to the idea of what is it that they want to do that they can't currently do, that we can kind of help them along the way with that. So in just really simple biomechanic terms, all of us probably know that balance is basically just keeping our base of support under our center of gravity. And we all do this all the time when we are moving about our day. So this is what we're always doing is we are always working to move our base of support underneath us, under our center of gravity, so that we don't actually lose our balance and fall. So obviously, this case, we're standing, base of support is under our center of gravity. In this case, we've moved our base of support forward, so it's under our center of gravity. But if we were to just bend over, obviously, we would fall. Now, as we get older, we tend to lose that ability to regulate our base of support, which is one of the things that puts us more at risk for falls. So what we are continually balancing as we get older is this idea of losing our balance and regaining our balance. So falls really have a lot of components to them, but they're from a failure of these two abilities. And so we really need both of these because if we lose either one of those, then we're basically going to run into problems with falls. And this is something that happens throughout the day for most of us. So if you think about it, you may stumble on a sidewalk, you may trip over your feet slightly, maybe you kind of lose your balance going up and down the stairs. And as long as you're able to regain your balance, you will not have a fall, which is important. Older adults tend to become more likely to lose their balance and less likely to regain their balance as they age. And that's for a variety of reasons that we will talk about. So what we really want to do when we're thinking about fall prevention is intervening on both sides of that equation. So we want to work on reasons that people are losing their balance, but also in helping older adults to develop the skills that they're able to regain their balance. So if you think about children, right, they do this all the time. So if you think about kids spinning, they're running around a playground, they're jumping over things, they're continually losing their balance, but they frequently have that ability to regain their balance to actually prevent the fall. So what is it that actually influences balance? And most of us are probably thinking back to our anatomy physiology classes when we talk about this. But generally, I kind of think about four systems that really influence our ability to keep our balance and also regain our balance as our fall. So generally, we tell people that it's their vision, it's the vestibular sense from their inner ear, it's the feeling on their feet, and then it's also going to be a proprioceptive sense or feeling of where our body is in space that we get from our muscles and our joints. And so it's important that we have kind of all of these systems working. But what tends to happen is as we age, we rely much more on our eyes than we do on these other systems, which may be fine and well if you are in a well-lit room, if you are in a room with an even floor. But what happens is as soon as you start to lose that sense of vision, maybe it's because you're now in bifocals and you weren't before. Maybe you're at the movies and they dim the lights. Maybe you're walking on stairs that don't have good contrast to them. All of those things are going to contribute to your risk of a fall. And so when we start to think about how we prevent falls, we start to think about how we can intervene on all of these systems together. Now, of course, we also have to throw in there that environment is a huge factor that actually takes place in a fall. And so we think about things like throw rugs. This is going to be one of the most common causes of falls. You can also think about other trip hazards, things like extension cords, furniture maybe that's in the middle of the room. Those are all things in the environment that can cause a fall. And the CDC actually has a checklist. I'll show you a page from this a little bit later on that you can provide to clients and to patients that will walk them through room by room in their house. And it will basically say, do you have these things in your house? This is a fall risk and should be taken care of. So this includes things like stairs and steps. So for example, is there clutter on the stairs and steps, right? In my house, the stairs become the area where my kids throw everything that needs to go up to their room. That, of course, is going to be a trip hazard. Are there broken stairs? Or are there problems with the handrail? Is there good lighting and contrast on the stairs? Is there carpet on the stairs? So carpet on the stairs may cushion a fall if somebody has it, but it also makes older adults more likely to fall because they're more likely to actually slip their feet, lose their balance, and have an inability to gain that balance while they're going down the stairs. Additionally, we think about things like bathrooms. So can they turn around in the bathroom? Are they able to get on and off the toilet safely when they do that? In the cabinets, for example, are they able to reach things in the cabinets when they are trying to move things around the cabinet? Do they have an adequate space that they are able to turn around when they're moving within their home? So these are all things that we think about in terms of trying to prevent a fall for an older adult in that environment. All right, so what I want to share here is I'm going to give you two videos. These are actually case studies that were published online on YouTube from the Lancet that look at falls in older adults. And what we're going to see are a couple of things here. We're going to notice changes in the base of support. We're going to notice the loss of balance, and then we'll also notice the lack of recovery that takes place in an older adult. So I just want to put out the disclaimer that these were actual falls that did happen. Again, these were published in a national case report, but it can be a little bit traumatizing sometimes to watch an older adult fall. So I want everybody to be aware that that is happening. So give me just a second to turn my pointer off here. So what you're going to see is this older lady is going to try and turn. She obviously loses her balance, right? She had a very narrow base of support. And when she attempted to do that, she tended to fall backwards there. All right, this is a slightly different scenario. But this again is an older gentleman. You're going to see that he's playing a game with the ball here. And I want you to pay attention to his feet. So he's initially going to start out with a very wide base of support. And while he's standing there, what you're going to see is he tends to trip over his feet, so he loses his balance, and he has a real inability to really gain that back. So again, you can see he's standing with a wide base of support, keeping his center of gravity under that base of support right here, trips, pitches his feet, and he's unable to actually catch himself, and so he falls. And the other thing that you may have noticed if you were really observant is both of these older adults tend to kind of fall in this backwards direction. And so we know from some of our research and research of others that when older adults do fall, the area that they are most vulnerable in falling is actually kind of back and to the side. And when you think about that, you might not initially think that we're moving all that often in those directions, but think about when you open a door and you take a couple steps back. So you open a door, you open a cabinet, you open the fridge. You're continually moving back into those directions where you are at a risk for a fall. When you turn, that would be another example of when you're moving in that direction. So these tend to be areas where older adults are really vulnerable for a fall. So what happens is in maintaining that balance and in trying to prevent the falls, we have both intrinsic factors and extrinsic factors. And one of the things we're told is if we never lose our balance, we'll never fall, right? which can actually be problematic in some sense because if older adults are never challenging their balance, then it actually gets to be worse over time. It decreases just like if they're never using their muscles. So, intrinsic factors that we think about that can contribute to actually balance and the ability to regain balance are things like medications, whether or not people have low blood pressure, their vision. So, we know that wearing bifocals are huge risks for falls. And if older adults have not had their vision checked, they should by a doctor. Inner ear vestibular function, like I said, proprioceptive, being able to feel your body in space, and then also our cognition and joint stability. Now, the good news is that we do know, even in older adults who have dementia, participating in a fall reduction program does improve balance and reduce the risk of falls. So while they may not cognitively be aware of why they're doing it, or they may not always remember what they're doing, we do know that there is actually muscle memory carryover from that that does help them in the prevention of a fall. Other things we think about are these idea of these extrinsic factors, so things outside of the individual. So these would be a lot of those environmental factors that we just talked about, things like lighting, stairs, footwear, the floor surfaces and obstacles, really what that CDC checklist goes over to try and prevent a fall. And it also includes things like crowds and pets. So pets are great for keeping people active. There's been studies that have been done in older adults who have dogs that show that they're more likely to be active, they're more likely to walk. There was a great study that was done where they actually assigned older adults either a dog to walk at a shelter or a walking partner. And what they found was that the older adults who were assigned the dog at the shelter walked a lot more than those who had a walking partner because they felt an obligation to that pet to actually get out to walk it. Whereas when they were assigned a walking partner, there was a lot more opportunity to make excuses of, oh, you don't feel well, you're not doing great, let's take the day off. But we also know that that's a dual-edged sword because if you do have pets in the home, particularly smaller pets that are likely to run in between your feet, those are more likely to cause falls. And so it's something that we always ask about in the home. Do you have pets around? Because it's just something that older adults need to be aware of. So this is really what we think of in a multifactorial falls prevention model. And it's looking at all of these things cohesively to be able to actually make a difference in falls. So what we do in our VA clinic is our VA clinic is duly staffed by both a physical therapist and also either an MD or a nurse practitioner, so that when older adults come in, we can try and do all these assessments at once to try and get them whatever it is that they need rather than having to go to multiple different locations. So we're talking about longevity and the connection of balance to longevity. As Ethel said in the beginning, we know that falls are a huge problem. So mobility problems are really the number one reason that older adults are going to be admitted to a long-term care facility. And it's usually when their family members can no longer help them get from chair to chair or in and out of the home or in and out of a car, that becomes a reason for long-term care admission. We also know that there's some really easy tests that you can do to check for this. So if you cannot stand on one foot for 10 seconds, which doesn't sound that long, but I encourage you all to try that tonight. So if you cannot stand on your foot for 10 seconds, you are twice as likely to die in the next 10 years as somebody that doesn't. And that's because there are so many consequences, health consequences to having a fall, that longevity or that achievement of a long life, balance is a really huge, important part of that.
Dr. Addison, we tried that last week at the training.
Oh, great. Okay, good. So you all know what your risk is now. So, all right. So consequences and prevention of a fall. As it was mentioned, we do know that falls are increasing in number and severity. And not only that, they're actually happening at younger and younger ages. And we're not totally sure why that is happening, but we know that they are occurring in younger adults. So, for example, while fall studies may use to only enroll people who are age 75 or older or 65 and older, we've actually moved in our balance and mobility studies to enrolling people who are 55 and older because we find that there are a number of older adults, particularly if they have a lot of health problems, who are at high risk for falls. And so we're trying to intervene on them at those younger ages. We do know that about 30% of those who are 65 and older fall every year. Well, it goes up to 40% once you reach the age of 75. We also know that half of fallers fall multiple times. It is the #1 cause of accidental death in older adults. And after somebody has had a fall, about 15 to 30% of those who've had a fall, who've had a hip fracture, will die within the next year, and another about 30% will be placed in a long-term care facility. So it really does result in this kind of high level of morbidity. But we do know that falls are preventable and that balance can be improved, which is really important. So what do we recommend for checking if somebody is at risk for falls? One of the things we do is that we recommend every older adult over the age of 65 be screened for a fall every year, just like a regular checkup. And this can be done by anybody, any healthcare provider, anybody they're interacting with. And it can be done by just asking really 3 simple questions. So, do you feel unsteady when you're standing or walking? Are you worried about falling? And have you fallen in the past year? And if any of those are a yes, it's an indication that that adult should be referred for further evaluation for maybe what's causing those problems. It's really interesting because there's been some studies done in older adults who fall, and they actually find that within a year period of the adults that they followed, 70% of the falls occurred in those who had never had a fall before. So while it's important to ask about, have you had a fall in the past year, that's not the only question that we should be asking. We find that the are you worried about a fall or are you feeling unsteady? Those are both important questions for really picking up that group who may be at risk for a fall but has not yet had one. There are also some measures that are out there. So this is again from the CDC, and I really like this one because basically what it does is, again, it's something that you can give to patients or clients. And you're just asking them to circle these questions, yes or no. Have you had a fall? Have you been advised to use a cane and a walker? Do you feel unsteady? And if their score is more than 4, then you know that they may be at risk for falling, and they really should be referred to their doctor or to a therapist to have a further checkup. The other reason that I like this questionnaire is it actually explains to the older adults about what they need to think about. So I am worried about falling. People who are worried about falling are more likely to fall. So it kind of gives a rationale to the questions and things for adults to think about that may prompt them to get further evaluation or treatment for that. So we've talked about falls. We've talked about consequences of falls. One of the things that we try to do to prevent a fall is, of course, to measure balance. And I'm sure all of you know there are lots and lots and lots of different balance measures that exist out there. There's literally hundreds of them. Most of these measures will assess some combination of balance, strength, and walking. So what I've included here today are 2 really easy measures that we've used quite a bit and that are easy to implement across settings, because what I find with a lot of balance measures is that they can be lengthy, they're difficult to do in the home, they're difficult to do in a clinic setting, they're difficult to do in a gym setting. So I like both of these because they can be done pretty much across different settings. So most of you are probably familiar with the timed up and go, the tug, which is basically where you have an older adult sitting in a chair, you put a cone that's about 3 meters out, they walk 3 meters out and come back and sit down. And so you're timing that. Now, you may be less familiar with this balance that's actually called the Q-Tug. So this is a company, I have no affiliation with this company, but I've used this device. This is from a company called Kinesis. And so this is something that is commercially available, but I like their Q-Tug screening because if you are not a healthcare professional that's continually dealing with this, but you want to screen older adults for falls, this is a great way to do it. And so their Q-Tug system has 2 little devices that are accelerometers that basically measure where people are in space that you put just on little neoprene sleeves that go on their legs. And then basically you do the timed up and go. And it asks you to input information on them about what their age is, had they had a fall, a couple of other questions. And then at the end, what you actually get is you get a score. So it tells you what their time is. You hit a button when they start going and then you stop it. It tells you their time, so it makes it really easy to do. But then it also compares them to age match norms, sex match norms, and tells you what their percentage is and how likely they are to have a fall in the next year. And so if you are trying to screen every year a large amount of older adults, their data can actually be stored here. And so you don't have to remember, what they did the year before, but it can give you a comparison over time. And their norms have been set up literally against thousands and thousands of older adults that they've had do this. So they have pretty good data to back it up. So again, this is a commercially available company I have no affiliation with, but I think if you're going to try to do some of this on a larger scale, this is something that can be pretty easily operationalized for other environments that can be done across settings. The other one that I like is what's known as the four-square step test. And so this, again, is a really simple test that can be done in about 30 seconds or so. And so I'll play this video here in a minute, but basically what it is either 4 canes that are put together, or you can get 4 PVC pipes with a little connector in the middle. And the idea is that you're starting in one square and you're trying to step and cover all the squares and then go back. Now, the research says that you need to do this in less than about 15 seconds or so. Our data says that it's probably less than 10 seconds to be able to know if somebody's a high fall risk. The reason that I like this is if you recall back when we watched those videos of the older adults that were falling, one of the things this test does, it actually forces older adults to move in that backwards direction. So you get an idea of how older adults are moving in all directions, whereas something like the tug, you really kind of get this linear direction. So we're not really screening in these multiple directions. And even a lot of the other fall or balance measures that we use clinically, they don't necessarily screen in that backwards direction. So we found a really good relationship between doing this test and then how older adults do in a fall rehab program, particularly when we're focusing on their muscles of their hips. So I'll play this video here for you so you can watch this. But this is one, again, that can be done in most locations if you have just enough space for them to be able to step over these canes. Oh, maybe I'll show it. There we go.
Four-step square test. The test procedure may be demonstrated, and one practice trial is allowed prior to administering the test. The timing is when the right foot contacts the floor in the square. The individual is instructed to try to complete the sequence as fast as possible without touching the sticks. Both feet must make contact with the floor in each square.
So that gives you an idea of the test. And one, I think, the interesting things that I found in doing this test with older adults is a lot of times, whoops, there we go, you actually don't realize, and a lot of older adults don't realize, that they have a fear of kind of stepping in that side direction or that backward direction until we actually challenge that and ask them to do it. So there's been a fair number of patients that we've had come in, oh yeah, I can do that. And when they start moving, they suddenly realize that they have a fear of moving backwards or stepping to the side. They're unable to do that in either one direction or the other. And so it lets us really understand maybe where some of their balance limitations are that we can actually try to help with. So when we think about falls in older adults, of course, falls in older adults, like we said, it's really multifactorial. And so these are kind of the areas that I think about as a therapist for needing to address to try and prevent the falls and improve balance. So one of them is an internal challenge to balance. So what it is within them that actually challenges their balance. So I kind of think about this as being the medical screening, and this is why we have a physician or an NP in our falls clinic all the time so that they can actually go over this portion of it. So in general, When you are thinking about medications, if somebody is on anything that makes them sleepy, makes them dizzy, makes them say, I feel loopy or goofy or spacey, they need to be very careful because this is something that could potentially contribute to their balance and their fall risk. So we see these a lot of times if patients are on medications for pain, that may contribute to that. If they're on medications for a neuropathy, that may also contribute to it. If there are medications to help them sleep, then that may contribute to it. In addition, we know that polypharmacy, of course, is a big problem for older adults. So if they're taking more than 4 to 5 medications, we really need to be careful with that because there's probably a chance for some interactions going on there that could potentially be impacting their balance. In general, we know that blood thinners, that being on them generally outweigh the risks. But if you do have a patient or a client who has a fall who is on a blood thinner, we need to have extra caution. So generally that warrants seeing a physician, being checked out, because we are worried about things like brain bleeds if they've had a fall. Even if they haven't necessarily hit their head, that is a risk that they may have from just having the act of a fall. We also know that good nutrition is going to be very important in kind of this medical idea. So making sure that there's a balanced diet. We always encourage older adults to get a minimum of 1.2 grams per kilograms per day for high quality protein. High quality protein being things like lean protein, so thinking about fish, chicken, soy, and then also making sure that they have enough vitamin D and calcium, so then they're of course not at risk for things like osteoporosis. So making sure that there's not a deficiency basically within those vitamins. So we have some of our studies where we work very closely with nutritionists and dietitians to really try to optimize what the diet is. So then whatever we're doing for an intervention program is kind of going to get the maximal benefit. We also think about these external challenges to the environment. And again, this comes back to that idea that I talked about before, the environment, the stairs, etc. And so this was the checklist that I mentioned from the CDC and their study program. So it has several pages, but I've just given the one here that talks about the stairs. And this can be distributed and used with patients. So they can actually take it home and check off things and say, yes, this is a problem, or no, this isn't, and helps them to really assess their environment to try and identify what fall risks that might have there. And then it actually gives some ideas that what it can do or how to make a difference there. And so the other thing that I frequently always recommend if we think that individuals are at risk for a fall is an OT home safety eval. So OTs are wonderful. They can come in and help to assess a lot of these things to make sure that patients are safe in their different environments and that they really, have what they need to move within their environment without being at risk for falls. All right, then the next three we kind of think about together, whether that be a disuse apraxia, a lack of endurance or muscle fatigue, or also a weakness or lack of power. And so what we think of for all of these are basically exercise, exercise, exercise as being the way that we intervene. So one of the things that we know as we age that tends to affect our balance is actually this idea of this loss of muscle quality. So what is muscle quality? Muscle quality is basically saying how well does your muscle function? And what we know from some really large, well-done studies is while we're losing about 1% of our muscle mass a year, we're actually losing up to 4% of our strength a year. And so this is a slide from the Health ABC study that shows that. So you can see the light gray bars are how much muscle individuals are losing. The dark black bars are actually how much strength they're losing. So what this tells us is, as we're aging, not only are we losing muscle, but we're also losing how that muscle functions. It's just not working as well. And what we know is individuals who have lower muscle quality are at much higher risk for falls. And so that's something that we try to intervene on and try to change to try and prevent that. So how do we actually maintain or improve our balance? We do know that exercise is critical to fall prevention. But just doing strength and aerobic exercise alone will not prevent a fall without targeted balance training. And this has been shown in quite a few different studies. So how do we actually maintain or improve that? In general, you need about 50 hours of balance training to prevent a fall. And what we really recommend is a multimodality fall prevention program. So what do we mean by multimodality? This means that we are interacting and we are trying to change all of those things that we just talked about. So in our environment, multimodality fall prevention includes targeted balance training. So we have individuals, this is somebody who was in one of our groups, working on stepping, their base of support, increasing that, being able to recover if they trip from a fall. So we will give them hazards and an obstacle course to negotiate. You can kind of see that walking over the ladder here. You can also see some of the ladders that we have in the middle. We also include how to get off the floor if somebody does fall. So this is actually one of the most critical things that we can teach and assess in older adults is, are they able to get off the floor? So while you may not feel comfortable assessing that, that is something that you could ask a client or a patient. If you did fall, would you be able to get off the floor? And if they say yes, you can follow that up with, when was the last time you tried to get off the floor? When was the last time you actually got off the floor? Because what we find is as we get older, there's much less of the getting up and down from the floor, and it becomes much more difficult over time. So we teach all of our patients how to get up off the floor so that if they are able to fall, it's easier to get up. Now, it's not always successful that they do it on their own. So we've had some patients who have gone through the program, and initially it took 2 firemen if they had a fall to get off the ground, and then they say, oh, I made progress because this time I was able to assist and it only took 1 individual. But that's still a positive step in that direction. Our fall programs also do include things like aerobic exercise. So you can see our group here riding bikes, recumbent bikes, and doing strength training as well. So that's what you can see here is we incorporate quite a bit of strength training, and then we always incorporate a group aspect in what we're doing. So we find in a lot of our fall prevention studies that a lot of our older adults really enjoy the group exercise aspect, and they actually push each other and do better when we create the community around them to be able to interact and do that. So that's really one of the things that we encourage quite a bit. Now, there are, of course, other types of exercise. So the next one I'm going to show you is a video, if it'll play, from a company called Gait Better. Again, I have no affiliation with Gait Better, but I've known therapists and other people that have actually used this in their clinics. And the state of Maryland, Aging, actually had a push to try and get these into senior centers around. So what the Gait Better system is basically if you have a treadmill, it's a harness that you can see here that goes on, and so that people are safe. And then it's a TV that basically has a virtual reality to it. And then you put some sensors on the feet, and so people walk and they try to negotiate or step over these obstacles. Now, the reason that this is nice is this does not take a professional PT to actually run. So this was designed so that it can be run by individuals who have some knowledge of balance and training, but not necessarily having to be a health professional because they are in the harness, they can be safe, and the program kind of advances as they go over time. So I'll play a video here. So what you're seeing here is they're walking, and then this is actually what they're seeing on the screen while they are walking. So that's what goes on their feet. This is the safety harness. And then you can see this is kind of the virtual environment. So they see their feet actually walking in that virtual environment. The other thing that Gait Better potentially has is it actually includes some dual task elements as well. So you can actually increase maybe how they're paying attention or what they're having to do, because we know that when older adults are distracted, that's when they're more likely to have a fall. And so that can be something that can be important to work on. And it's nice that there's a potential system out there that can be implemented, again, without a need for a PT. So it probably wouldn't replace PT, but it could maybe help to adjunct things that older adults are doing in other ways to keep their balance up. So rather than saying, if we never lose our balance, we will never fall, we like to say, if we always regain our balance, we will never fall. Because the chances are you're going to lose your balance at some point in time, but you want to be able to regain that. So we talked about a lot of, the physical and the mobility aspects of what we see in a lot of our patients. One of the things you might be asking is, how is this actually impacting the patient? Or, how are they responding to the fall training? So I always keep a list of quotes as people are going through it, of things when they tell me that they can do that they couldn't do before. And I think that these are important to remember, because this is really central to who they are as patients and what's going to motivate them to keep going. So I can stand up after working on my car, or I can fish on a floating dock again. I remember this older gentleman was really excited to be able to take his grandchild fishing again. I can walk up the stairs carrying my laundry. And then these two are two of my personal favorites that we've heard. Exercise is getting harder, but life is getting easier. And I went out on a date and I forgot my cane at home, as an indication for their balance really improving. And so it's important to remember these are really central to what we're trying to get at with that idea of longevity. Not only are we helping to extend life, we're hopefully helping to make their lives better while they go. So we know exercise works. We know fall prevention is important. So why might people not actually be doing it? And there's a whole lot of reasons why, but we've been doing a study here at the VA to actually try and look at the barriers and facilitators for helping veterans to exercise, helping them to eat better in an attempt to actually improve their mobility. So what we found is in our reports, and these were from about 90 veterans, both in Baltimore and in San Antonio. So we were really trying to target Hispanic and Black populations, because they tend to be underrepresented in this data. And what we found is that 41% say that they don't have exercise equipment, that they don't have skills or coordination to exercise, about a third, which I think is really interesting, because veterans are a population that their job actually depended on them being active and exercising for a while. So it's interesting that as they age, about a third of them say that they no longer have those skills or coordination to exercise. About a third say that they really have difficulty in finding places to exercise, and they have difficulty in finding people to exercise with. So they really do tend to enjoy, in our population at least, that group environment. They find that to be something that keeps them coming back. But I thought it was really interesting that 90% said that they could make time to exercise in their day if they were given some of those, other things like space and equipment. So this again can be a way to connect people, to ask why you're not exercising, instead of just, are you exercising, yes or no? Well, what is it that you don't have that you need to exercise? How can we get you connected with that? And one of the things we know from our clinic is that transportation tends to be a huge issue. So we do know that racial and ethnic minorities, those with lower incomes, older adults who have really high comorbid disease burdens, are much more likely to have problems with transportation. And actually, transportation is the #1 reason that we have missed visits in our Falls and Balance clinic. And so that's something that, if we can connect older adults with those right mechanisms to get to their appointments or get to those fall prevention programs, that's really important. We also know that there is a need for actual community engagement. So we're more likely to make changes when we engage with the patient's culture. We understand what's important to them. We understand what they're doing and what they're not doing and why that may be. So in general, a program that's actually going to embrace a patient's community, that is community-based and has a strong emphasis on social supports, That has been shown what is going to work the best. So one of the things I think I've realized and come to understand that you all are probably very good at is needing to understand the patient's attitude towards balance and exercise to actually improve it. So when they say, I'm not doing it, why is that? Are you afraid of exercise? Is there another reason that you're not exercising? So, for example, with older women, we find that incontinence may be a problem and they're sometimes embarrassed to admit that. They may not have the skills to do that because they hadn't done it when they were younger. We find frequently that older adults may not be doing it because they're caring for a spouse and they may not be able to get away, or their spouse may have difficulties exercising and they don't want them to feel excluded. So reading into some of those, understanding those nuances more are all going to be important to making sure that we can actually address some of those problems that we have with balance and mobility. So just to wrap it up and bring it all kind of back together to the graph that we had looked at before, when we again think about that successful aging, normal aging, chronic disease, falls are going to be a big factor in where people are falling on that spectrum and how close they are getting to that frailty idea. And so we again may not be able to actually move older adults from one line to the other, but hopefully what we can do through some of these balance and falls interventions is actually kind of push them back up the hill a little bit so that they are older when they actually reach, if they ever reach, that frailty spectrum. So with that, I just want to acknowledge all the people that I have worked with on all of our fall reduction studies through the year. This is a lot of the therapists that I work with in one of our labs. And then also, of course, our wonderful older adult patients. You can see them here in our GeroFit program that are participating in some of our falls and balance activities that we had to try and keep them young and healthy. And with that, Ethel, I'll open it up to questions.
Outstanding. Thank you, Dr. Addison. That was a wonderful presentation. I've gotten several questions. First of which, if joint pain affects your balance, would you recommend adding daily supplements?
That's a great question. So I would say any supplements you need to talk about with your doctor to make sure that they, agree with the supplement use. We do know joint pain is a condition that influences balance and falls. We also know that exercise can be tailored to joint pain. If we can strengthen those muscles, it tends to decrease joint pain and it tends to improve balance as well.
The next question I have is, can you outline how dementia affects the risk for falls?
Yeah, so it's a great question, and this is really an ongoing area of research. It's not my research personally, but we know that there's a lot of factors for dementia that are likely, or even impaired cognition, to influence falls. So one of them is going to be medication usage, right? Like we talked about. So if you're not able to properly manage your medications, then you're more likely to have an incident related to the medication and have a fall. Another one is that it's just an awareness of what's around you, an awareness of risk factors. There may be some judgment issues with the cognitive decline of what actually is an acceptable risk versus an unacceptable risk. So more likely risky taking behavior that may result in a fall. But when it comes to the actual muscle joints, we know that that's not necessarily associated with all types of dementia, which is why if we put individuals in a fall reduction program, we can actually change that. The other thing that we know tends to happen with dementia that may contribute to falls is there's this idea of caregivers actually limiting what they're doing because they're afraid of them falling, or maybe they're afraid of them eloping. And so they actually do a lot more of the let me do that, let me do that. So over time, individuals actually develop this disuse atrophy. So they're not using it, so they tend to lose it. So that also tends to happen quite a bit with dementia.
And similarly, I received the question about hearing. How does that affect falls?
Yeah. So hearing we know affects cognition, and we also know that the inner ear also influences, our balance and our vestibular system. So hearing itself may not, but when there is a loss of hearing, the question is, what else within the ear is actually being affected. And so if you are losing that vestibular system or the input of that vestibular system, then you are more likely to have a fall.
Understand. Getting so many comments that they love the examples of the video screening tools that you provided. That was very much appreciated. How would a veteran in someone's case management get involved with your program?
Yeah, so GeroFit is at about 30 sites across the country. We also have a virtual program. So it is just a referral through their PCP if they are in the VA system. So for GeroFit specifically, they need to be in the VA system. If they are not in the VA system and somebody has a patient who is a VA and they're interested, a veteran, they're not in the VA system, and being one of our studies, you can certainly contact me. We can take veterans in our studies who are not in the VA system as well.
You had mentioned in your presentation about cultural implications to balance and falls. Can you outline some of the groups that may be affected by that?
Yeah, so I think cultural implications, anytime you think about, where people are living, that has a big influence on falls. We also know, for example, if you're thinking about inner city Baltimore and when patients are walking down the street, it may not be safe for them to walk down the street. And that may have nothing to do with neighborhood violence or anything else, but just simply the fact that there's cracks in the sidewalk, the curbs are deteriorated, there's not good signage, the sidewalks may not be wide enough for them to use a walker or a cane if they need to, right? So those are some of those cultural implications that take place. I think there are also other cultural implications that take place when you think about how older adults are treated in a culture and what's expected versus not expected. So if an older adult is injured and the general cultural idea is they shouldn't move, they should stay there and we should do everything for them, that's likely to result in a deterioration of their balance. And sometimes that's done. I've had some patients where that's a sign of respect for an older adult, but we've had to have conversations with the family about no, they really do need to get up. They need to be doing this for themselves. Otherwise, they're going to continue to deteriorate. And so that's some of what we've seen with some of those cultural considerations.
Perfect. Just an add along to the question prior, how can they get information to share with their clients about this program that you work with?
Yeah, so Ethel, I can send you all, I have a list of resources. I also have a list of our recruitment line phone number for some of our balance studies. And I can send the information for GeroFit as well. So I have that in a Word document, and if I send it to you, you feel free to distribute it.
Oh, perfect. That would be great. Does diet prevent fatty infiltration?
Oh, great question. We didn't touch on fatty infiltration, and that's my passion topic. um, so diet can help prevent fatty infiltration, but it also does take exercise. So it's probably a combination of diet and exercise. So we know in triathletes who are extremely active, a 40-year-old triathlete has the same looking muscle as a 70-year-old triathlete. And so it's really probably the combination of diet and exercise together, along with probably some genetics that make a difference in that.
Someone asked, can you just define what fatty infiltration is?
Yeah, that's a great question. So, fatty infiltration is basically if you think of a steak, right, and you think of the lines of fat that marble a steak. We like that in cows. We do not like that in humans. And so humans get something similar where as we age and we tend to lose muscle, we get more of this fat that actually works itself in between the muscle fibers and creates a whole host of problems.
Gotcha. Um, Next question from Maria is, how does vertigo impact falls with the elderly?
Yeah, so vertigo is a huge risk for falls because basically people lose their spatial awareness when they're having an episode of vertigo. And so it makes individuals really, really high risk for falls. So if they can see an ENT or an audiologist, then that can make a difference because there's a lot of different causes of vertigo. Excuse me, it could be a medication they're taking, it could be a nerve problem, it could be some other problems that are related to that. And so getting to the heart of what is causing the vertigo is going to be really important to treating that.
Next question from Diana is, the screening tool that you outlined, QTUG, Is that a free application or is there a charge involved, and is it on any app store or phones?
Yes, it's
Whatnot?
a great question. So the Q tag itself actually has things that go on the legs, and so it's something that is available for commercial purchase. But they do have a free screening app actually online that older adults can go in and do themselves to screen if they are at risk for falls.
And if you were advising a client, what would you say are the top 5 exercises older adults can do to prevent the risk of fall?
Yeah, that's a great question, and I will be honest, I have debated this with my own father. um, so I think in general, doing exercises that are focused on lower extremities are going to be really important. So things like squats, lunges, side steps, and then kind of walking in a narrow base of support are generally what we do with older adults. And we work not only on those exercises, but we also work on varying the surface that they're on. And then we work on varying the speed. So trying to really encourage them to move quickly sometimes and then slowly others so they're able to regulate their speed. So if they do catch their toes or do something like that, that they're able to recover when that happens.
Awesome. Next question that I'm seeing coming in is that do you recommend weight training?
100%. So I think the more and more that we learn about strength or weight training, we learn just how really critical it is and how many implications it has. So there's been some recent literature that's come out in postmenopausal women in particular that suggests that weight training can actually improve fatty infiltration and also fat, in the body in general. So strength training is really critical because that is one of the ways that we change muscle quality.
Adding on that question, you mentioned menopausal ladies. Is it better to do aerobic activity or the weight training in order to lose weight?
Oh, that's a good question. So losing weight really has more to do with your caloric intake than it does any type of training that you're doing. I think it's important if you are trying to lose weight to do resistance training because we know if you're reducing the calories you're eating and you're losing weight, you are going to lose muscle mass. And so one of the ways to try and prevent that is to do resistance training. So that becomes really important. But what they found in studies is doing aerobic or resistance training does not directly lead to weight loss because what tends to happen is we all go, oh, I deserve that treat. I'm going to go ahead and eat this because I did this exercise. So we actually end up consuming more calories unless we're being really aware of it.
Our next question is tuning into, I believe, your currently funded program. Are you finding greater results with weight loss plus exercise or just exercise on improving mobility?
Yeah, so I will be honest, this is kind of a controversial topic in the aging community. So there was a really famous paper that was published in the New England Journal of Medicine in about 2011 that showed that exercise plus weight loss resulted in the biggest improvements in mobility, but it also resulted in the largest decreases in muscle mass. And so it's still a little bit controversial of whether or not we should be doing weight loss in older adults. In our studies, we actually have not found much of a difference between the two groups. So it looks like for our group, at least, it was really kind of the exercise component that was critical.
Do we find that older adults who had hip replacements are more at risk for falls?
Yes, that's a good question. So in general, yes. It's kind of a nuanced answer because hip replacements, they can do those in a couple different ways. So if they are coming from the back, meaning they make their incision through the back of the gluteal muscles, that does tend to increase your risk for falls because you're basically cutting through a lot of these muscles that we use to recover from a fall. And those muscles have a difficult time recovering after. If they are coming from the front, then there may be less of a risk for falls because there's less of those muscles that are actually damaged when they're doing that.
Akuma is wondering that is there more of a risk of falls with individuals that have a low support system?
Yeah, so this is not something that I have studied personally, but I do have a colleague, Jason Falvey, who studies some of this. And so that's something that we're actively looking into. And it makes sense that that would happen because we do know that when people tend to have a low support system, they also tend to be more socially isolated. And we know that that is something that is associated with the risk of falling.
Excellent. Um, Environmental conditions and the risk of fall. What do you think are the top 3 environmental hazards that affect falls?
That's a great question. Throw rugs, I would say, are probably the top number one. If I could advise a client on anything, it would probably be throw rugs because those tend to be where most people tend to trip. Um, Probably things around their bed at night, right? If they have to get up to urinate during the night, making sure that they have a clear path to the bathroom. And I think the other thing would be good lighting. So making sure that they have an easy way to turn on a night light or something else when they are getting up are probably my top 3 recommendations.
Okay, let me just glance through. I think I may have reached all the questions that came. I believe so. Do you have any words in closing that you would like to share?
I'd like to thank everybody for this, and I would just say I think fall prevention sometimes gets the rap of it's just the PTs or the MDs that do it, but I think really it is best when it's coming from the whole community. So again, just asking people if they've had a fall, if they have a fear of falling, if they've been imbalanced, and then getting them connected to the right resources. If they answer yes to any of those, can have a huge implication for reducing falls.
Um, Question just popped up in relation to that statement. Do you know of any community resources that you would recommend for fall prevention programs?
Yeah, so I will, in that link as well, include some of the resources for programs that are evidence-based. And actually, a lot of the aging centers around do run these different programs for fall prevention because we do know that it's so important.
Excellent. I'd be remiss if I didn't do a commercial for the Department of Aging. We do, and all of our 20 senior centers have outstanding exercise and fitness classes that individuals can participate in, as well as 14 of our centers have fitness centers that are about $80 a year, if I'm remembering correctly, with senior-friendly apparatus. I encourage everyone to connect their clients to those opportunities. Thank you so much, Dr. Addison, for being a part of our program today.
Thank you for having me.
All right, everyone, we're going to take a short break. We will come back at 1:45. Our next program will be Advancing Equity for Older Adults. If you have any questions, please feel free to contact our office at 410-887-2002.
So the topic is Advancing Equity for Older Adults, the implications of healthcare and social isolation among the older adult population. So with the aging population rapidly growing, more older adults will face the impact of inequalities in various aspects of their lives. So a few objectives that I'm hoping we can cover today. Next slide, Deja, please. Is to review the demographic shift as it relates to the older adult population, to understand intersectionality and social determinants of health and what they teach us about intersectionalities, inequalities, I'm sorry. We're going to be able to identify root causes of inequalities, review and understand healthcare inequalities among older adults and the role of Medicare and Medicaid in these disparities. We're going to try to understand racial health disparities and its intersection with healthcare inequalities. And we're also going to understand social isolation and loneliness in their intersection with healthcare inequalities as well. And then finally, we'll review some strategies to advance equity for older adults in the delivery of services. And if there's time, there are a host of resources pertaining to older adults that I've left at the end of the slides. Right, next slide, please. So populations around the world are aging rapidly, and this is leading to a growing proportion of older adults in many societies. So with this demographic shift comes an increased need to address the unique healthcare needs and challenges that are faced by older adults, to include disparities in access to healthcare and healthcare outcomes. So the number of older adults in America is projected to shift really big. By 2025, there will be a 47% increase in the older adult population. And this jump is from, by 2025, there will be a 47% increase in the older adult population. And that's a jump from 58 million in the year of 2022 to 82 million older adults by 2025. Additionally, it's also important to note that the older adult population is becoming more racially and ethnically diverse. So between 2022 and 2050, the share of the older adult population that identifies as non-Hispanic white, that's projected to drop from 75% to 60%. So these trends, of course, they represent one of the crowning achievements of the 20th century. However, these trends, they also pose significant challenges and opportunities. We can definitely attribute these demographic shifts to a variety of factors. So for an example, infectious diseases that once cut millions of lives short, they've been largely controlled in the US. And we can also attribute some of these trends to public health campaigns, for example, campaigns around smoking cessation and how those efforts have contributed to saving many more lives. So societal aging can impact economic growth, patterns of work, and the ability of governments to provide adequate resources to older adults. A growing aging population also means higher use of the healthcare system and its services. And so as professionals in the field of aging services, it's definitely important that we understand the inequalities facing older adults, what the impact of these inequalities are on service delivery, and identify strategies to advance equity in the delivery of services. So as we begin to piece all of this together and put everything into perspective, let's first look at intersectionality and social determinants of health and what they teach us about inequalities. Oh, back one slide back, Deja. So to understand intersectionalities among older adults, we're going to, like I said before, understand the intersecting nature of disparities. So we'll take a look at intersectionality and social determinants of health and what they teach us. So intersectionality, it recognizes that individuals hold multiple identities simultaneously. And these identities cannot be examined in isolation from one another. So instead, they intersect and interact to shape individuals' experiences. They shape our opportunities and the access that we have to resources within society. So for an example, a woman of color may face multiple forms of discrimination, like compounded forms, based on both her race and gender, leading to unique experiences of inequality that may differ from those of white women. Another thing that intersectionality does is highlight how systems of oppression, such as racism and sexism and homophobia and classism, how they all intersect and interact to produce complex patterns of disadvantage and marginalization. So an example of this would be, let's say, an LGBTQ plus individual who also belongs to a racial or ethnic minority group. That individual may experience compounded forms of discrimination based on the intersection of homophobia, transphobia, and racism. So, in short, what does intersectionality teach us about inequalities? Well, it teaches us that inequalities are complex and multifaceted, and they can't be fully understood or addressed just by considering one aspect of identity or social category. You cannot do this in isolation. Instead, it emphasizes the interconnected nature of various forms of oppression and privilege, which intersect to shape a person's experiences as well as their outcomes within society. Intersectionality also encourages us to consider the intersecting factors that contribute to disparities and to develop solutions that address the root causes of inequality across multiple dimensions of identity. Next slide, please. So social determinants of health, they are non-medical conditions that influence health outcomes. And they are conditions in which people are born, where they live, where they age, where they work, where they play or enjoy social activities. These conditions are determined by the distribution of money, power, and resources, and they affect a wide range of health and quality of life outcomes. It is estimated, according to the CDC, that these conditions, ranging from structural racism to socioeconomic factors, they drive 30 to 55% of health outcomes. The impact of social determinants of health on older adults are plenty. According to the CDC, again, as well as information obtained from the U.S. Department of Health and Human Services, social determinants of health have a major impact on health, well-being, and quality of life. And they significantly affect our chances of staying healthy as we age. So, what does social determinants of health teach us about inequalities? Essentially, these determinants of health, they teach us that inequalities in health outcomes are not solely determined by biological factors or individual choices, but they are heavily influenced by social, economic, and environmental factors. A core principle of public health is that everyone should have access to health services to reach their full potential of health. So it's important that social determinants of health address the differences and make progresses toward health equity, so that there is a state in which everyone has the opportunity to attain their highest level of health. Next slide, please. So another important point to understanding inequalities is to understand what the root causes of inequalities are. Next slide, Deja. Inequalities have complex and multifaceted root causes, and these causes are often very deeply rooted in in societal structures, as well as in historical legacies. So some key root causes of inequality, they include discrimination, which is the unjust or prejudicial treatment of individuals or groups based on certain characteristics or attributes, institutional bias, also known as systemic bias or structural bias. They refer to the pervasive and ingrained patterns of discrimination or unequal treatment that exists within institutions or organizational systems. Unequal distribution of resources. This refers to disparities in like the allocation and access to essential goods, services, opportunities, and benefits within a society or community. Unequal distribution of resources often intersects with other factors such as race, ethnicity, gender, socioeconomic status, and other dimensions of social identity. And all of this leads to systemic inequalities and disparities. And then, of course, there are historical injustices. And these historical injustices, they refer to past actions, past policies, past practices, all that have resulted in harm, discrimination, or oppression against certain individuals, groups, or communities. So knowing the root causes of inequalities is very essential for designing effective interventions, for preventing their perpetuation, for allocating resources, empowering communities, and building alliances to promote social justice and equity. So let's take a look at a few examples of root causes of inequalities. So historical injustices, they've played a significant role in creating deep-rooted disparities and inequalities that persist across generations and also in various aspects of society today. These injustices, they're often systemic and they have long-lasting impacts on marginalized communities. So for an example, research has shown that being born under Jim Crow laws has had lasting negative effects on infant mortality, on premature mortality, and even breast cancer rates among Black Americans. Research has also suggested that the durable effects of redlining, the institutional practice of limiting investment in low-income neighborhoods, it sets some populations back for generations because housing, as we know, is one of the main ways in which people in the United States can build wealth. And unfortunately, if you don't have access to housing, you don't have access to wealth. So these are just some historical justices that are root causes of inequalities. So another example that we'll look at is the institutional bias of race, of ageism. Ageism is definitely a form of discrimination and prejudice, and it involves stereotyping, prejudice, and discrimination against individuals or groups based on their age, typically towards older adults. So ageism can manifest itself in various ways, including through attitudes, beliefs, practices and policies that devalue, practices and policies that marginalize, or policies and practices that even stereotype people based on their age. So for an example, an older adult may experience ageism in a healthcare setting where their symptoms or concerns may be dismissed by their healthcare provider or attributed solely to their age rather than them receiving appropriate diagnosis and treatments. Ageism in healthcare can contribute to disparities in access to quality of care, as well as to disparities in health outcomes. So in addition to marginalization in healthcare, other ways ageism manifests itself is through social exclusion, ageist policies and practices, and of course, media representation, what we see in our commercials and in our television shows as it relates to the older adult population. Next slide, please. And so another example, a third example of a root cause of inequality is discriminatory policies or practices that affect access to healthcare. So with this here, these discriminatory policies and practices can manifest themselves as well in various forms, and ultimately they lead to unequal access to care, disparities in treatment, and differential outcomes for certain groups. So provider discrimination, for an example, can result in disparities in access to quality care. Examples include racial profiling, implicit bias in clinical decision-making, and disparities in pain management and treatment recommendations based on a person's race. So discriminatory practices perpetuate mistrust, of course, for the healthcare system, and they contribute to health disparities as well. And so policies that restrict access to reproductive health care based on religion or ideological beliefs, they disproportionately affect marginalized populations, including women of color and low-income individuals, as well as those of the LGBT plus community. And then when it comes to immigration status discrimination, this is essentially the fear of deportation and the disparity of language barriers and having to navigate those barriers within the healthcare system. A lack of healthcare insurance or coverage, as well as restrictions on eligibility for public health programs. All of these things can prevent immigrant communities from seeking needed care, which also leads to disparities in health. So discriminatory policies such as exclusion in health insurance coverage for transgender-related care, for an example, as another policy or practice that affects access to health care. They limit access to medically necessary treatments and contribute to disparities in transgender health outcomes. So again, these are just a few examples of discriminatory policies or practices that affect access to healthcare. So now that we have some history and context behind inequalities, let's look specifically at healthcare inequalities and their impact on the older adult population. Next slide, please. Thank you. So in understanding healthcare inequalities, let's first define it according to the Center for Disease Control and Prevention. And I quote, preventable difference health, I'm sorry, and I quote that the Center for Disease Control and Prevention, they define disparities as preventable differences in the burden or disease, injury, violence, or opportunities to achieve optimal health that are experienced by populations that have been disadvantaged by their social or economic statuses. Geographical location and environment are also factors. So healthcare disparities for older adults essentially refers to differences in health outcomes, differences in their access to healthcare services, quality of care, and health-related behaviors. Among the older adult population, there are various factors that influence healthcare disparities, such as an individual's race, their ethnicity, their socioeconomic status, their geographical location, their gender, their sexual orientation, etc. However, disparities exist in the quality of care that's received by older adults. And with so many populations receiving lower quality care compared to others. So I'm trying to think of how to word it. So I guess I'll say that the disparity here is that this could be due to biases among healthcare providers, language barriers, or cultural differences that affect communication and understanding between older adult patients and providers. And so stigma, that also plays a role in health disparities as it's attached to health conditions most often experienced by older adults. For example, dementia is a health condition most attached or experienced by older adults, and it can hinder early diagnosis. Stigma in healthcare can prevent early diagnosis of a disease such as this dementia. And then as older adults reach advanced age, meaning those who are 85 and older, they often experience more bias when using the healthcare system. And that's simply because they are older and they face challenges that can have negative effects on their health outcomes, therefore raising the total cost of care. So addressing healthcare disparities among older adults, it requires a very well-rounded approach to include addressing policies that are aimed at improving access to care, culturally competent healthcare services. It involves health education initiatives, and of course, efforts to reduce socioeconomic inequalities. Next slide, please. And so speaking of socioeconomic inequalities, these are the impacts of social economic inequalities on the access of healthcare services for older adults. So more than 17 million, or roughly 1 in 3 older adults ages 65 and older, are economically insecure. And with incomes below 200% of the federal poverty line. So that means that they have extremely, extremely low incomes. Additionally, older adults with low socioeconomic statuses, they tend to be at risk of not accessing health care and having several unmet health needs, especially those living in health resource limited settings. So in environments where they don't have the resources for adequate health care. And most older adults in the United States, they have at least one chronic health condition, making access to affordable quality care a priority. And as many older adults, ages 65 and older, transition to Medicare, they are then burdened with the imposing cost of Medicare. And unfortunately, when this occurs, many adults must make trade-offs between basic goods like purchasing clothing or purchasing food or even purchasing their prescription medications or over-the-counter drugs. They have to make these trade-offs in order to pay for their healthcare needs. And so while public health programs such as Medicaid and Medicare provide insurance coverage in effort to bridge the gap of healthcare inequalities, there are still disparities in access to healthcare services using these public health insurance programs. Next slide, please. So with that being said, one of the questions that I pose when thinking about inequalities is, do public health programs such as Medicare and Medicaid play an effective role in reducing disparities, unmet needs, and delayed care? So Medicare and Medicaid, as we know, are two very crucial pillars of the United States healthcare system. And both of these types of insurances play a critical role in ensuring access to healthcare services, as well as supporting healthcare infrastructures and promoting economic growth. And so I can speak for me personally, being in the field of working with older adults, I do see a lot of older adults who are using Medicare, Medicaid, or a combination of both. So drawing off of that, let's just look a little bit more into the use of Medicare and Medicaid among older adults, those who are 65 and over. Thank you, Deja. So according to the data collected from the CDC, the percentage of older adults ages 65 and older who are covered by both private health insurance and Medicare decreased. It decreased from 47.9% in 2017 to 39.6% in 2022. So this data, it reflects how older adults have an increased reliance on Medicare coverage alone. They're no longer having a secondary coverage to go along with it. In 2022, there was a 98.9% Medicare coverage rate for adults 65 and older, while Medicaid provided health coverage to 7.2 million low-income seniors who were also enrolled on Medicare or duly eligible. So as adults age, like I previously stated, they begin to shift from private or employer-sponsored health insurance plans to Medicare or dual eligibility, making them eligible for a combination of both Medicare and Medicaid, depending on their circumstances. And with the increased utilization of these public health insurance programs, it's important to understand that they may, and when I say they, older adults may experience further health care inequalities or compounded health care inequalities compared to their counterpart who is able to continue under a private MCO or health insurance plan. So with that being said, I think it's important that we take a slightly closer look at some of the disparities of older adults who are Medicare and Medicaid beneficiaries. Thank you, Deja. So disparities in health outcomes for the Medicaid and Medicare beneficiaries, these outcomes are well documented. A lot of research out there pertaining to disparities for this population as they experience higher rates of chronic conditions, disabilities, and premature mortality. Factors that contribute to these disparities may include socioeconomic factors, environmental influences, as well as unequal access to resources for healthcare. So for an example, individuals from low-income backgrounds, they may face greater challenges in managing chronic conditions such as diabetes and hypertension, and this leads to poor health outcomes over time. So Medicaid and Medicare recipients, they experience disparities related to social determinants of health. And these factors can have a significant impact on individuals' health and well-being, affecting their ability to access healthcare services, as well as adhere to treatment plans and maintain their overall health. And then racial and ethnic disparities, they persist within the Medicaid and Medicare populations, where certain minority groups face higher rates of uninsurance, as well as limited access to care and poorer healthcare outcomes compared to their white counterparts. Structural inequalities, including racism and discrimination, contribute to these disparities as well. Additionally, research suggests that payers and health plans do not adequately support or incentivize clinicians and healthcare delivery organizations to meet the specific health needs of minoritized communities. And some individuals are eligible, like I said before, for both Medicare and Medicaid. And I guess in the world of healthcare, they are referred to as dual eligibles. And so this often, and when I say this, I'm referring to dual eligibility, often have significant health, these individuals often have significant healthcare needs and may face challenges in coordinating care between both of the programs. So these individuals may experience disparities in access to long-term care services and support. Because Medicaid, for an example, may provide coverage for these services while Medicare does not cover them comprehensively. So they are left in deficit as far as receiving these services, having an out-of-pocket cost, and even understanding which of these two insurances will take precedent over the other. Next slide, please. All right, so what's being done about it? What are Medicare and Medicaid's efforts to reduce disparities within the older adult population? So starting with Medicare, Medicare's history actually began with a monumental impact on disparities in that even before the inception of Medicare, Medicare forced hospitals to desegregate, and they mandated this take place before it began paying benefits out to these hospitals who wanted to participate under this public health insurance. So until 1965, most hospitals across the country were segregated, where Black physicians, they weren't granted privileges in white hospitals, and Black patients were not admitted in many white hospitals. And if they were segregated by floor or by room. So in 1965, as a condition of participation in Medicare and to be eligible for reimbursement, hospitals were required to desegregate. And this helped to break down some of the barriers of segregation. And so another approach that Medicare has taken to reducing disparities is the introduction of Medicare Advantage plans that are used to cover costs that are not included with traditional Medicare. This is another effort that they've made. So this Medicare Advantage plans, they include coverage for services like dental, vision care, hearing, maybe a gym membership, and some coverage for over-the-counter allowances. And all of these services are not covered through traditional Medicare. So this is an effort that Medicare has made to bridge the gap. And thirdly, a big effort that they've made to reduce disparities within the older adult population is the universal nature of Medicare overall, in the sense that Medicare limits the number of older adults who are without some level of medical insurance. So even if they only have Part A and Part B, they have some level of insurance. And this is because Medicare is primarily designed to provide health insurance coverage for individuals, of course, who are 65 and older. And it's not based on certain geographical stipulations or identifiers. If you are within a certain population, then you qualify for this Medicare. So nearly all adults in this category become eligible. And it doesn't vary by state. And so the last thing I'll say about Medicare before I move to Medicaid is that Medicare has implemented quality improvement programs that are aimed at improving healthcare outcomes and reducing disparities among the beneficiaries of this insurance. So these programs may include initiatives to reduce hospital readmissions, which is really important, and improved care coordination, as well as promoting evidence-based practices. Thank you, Deja. And so here are some ways that Medicaid works to address disparities. Medicaid is that insurance that pays for premiums and cost sharing for those individuals who are also enrolled in Medicare. And Medicaid is a major source of financing for care delivered by certain providers, particularly providers who are in safety net institutions where they serve both low income and uninsured individuals. State Medicaid programs have added non-clinical services designed to keep seniors in their homes by paying physicians and other healthcare providers to deliver care to seniors and to those with disabilities right in the confines of their own home. Another effort that Medicaid has made to bridge the gap to reducing disparities are implementing the home and community-based services programs. These programs, they received approval through federal waivers to add non-clinical services designed to keep Medicaid members in their homes with assistance for household activities and ADLs, such as cleaning, dressing, bathing, and meal preparation. And lastly, Medicaid programs, they often engage in targeted outreach and enrollment efforts to reach eligible individuals, including racial and ethnic minorities, also including individuals with limited English proficiency and other undeserved populations. So these efforts alone, they help to ensure that those who are eligible for Medicaid are aware of the program and can successfully enroll. So let's talk about racial disparities in healthcare, or racial health disparities. This is important because across the country, racial and ethnic minority populations, they experience higher rates of poor health and disease outcomes in a range of health conditions when you compare that population to their white counterparts. So these disparities, they do have well, let me back up. These disparities, they have been observed, I should say that in the United States over a long period of time, and they are definitely influenced by a complex interaction of social, economic, environmental, and healthcare factors. So racism is a system consisting of structures, policies, practices, and norms that assigns value and determine opportunity based on the way people look or the color of their skin. Racism is not limited to easily identified bad actors, but it manifests personally, it manifests institutionally, as well as structurally. In both interpersonal and structural racism, they negatively affect the mental and physical health of millions of people, and this prevents them from attaining their highest level of health, and consequently affecting the health of our nation, because it's all compounded. Structural racism, it has definitely caused inequalities in other areas such as wealth, income, education, and housing, as well as, I should mention, incarceration and employment. And so these disparities, they lead to exasperating health conditions and inequalities. So research supports that racial and ethnic minority groups throughout the United States experience higher rates of illness and death across a wide range of health conditions, to include hypertension, obesity, and asthma. And there's additional data that suggests that the life expectancy of non-Hispanic or Black Americans is 4 years lower than that of white Americans. So the reality is that American medicine, it does have deep-rooted, troubled racial history. And to fully understand the implications of racial health disparities, it's important to understand the historic events that led to them. Next slide, please. So some historical references of these events that have happened throughout history are the Tuskegee experiment that occurred from 1932 to 1972, Miss Henrietta Lacks and the HeLa cell line, and Dr. Susan Moore, which was a more recent historical event that occurred in 2020 during the height of the pandemic. And so I won't go into all of these because I know that we are coming up on time. So I will skip to the next slide, but please reference those on your own time just for some additional historical content. So social isolation and loneliness and their intersection with healthcare inequalities. And I brought this up because this is a trending topic within the older adult population or the older adult community. Next slide, please, Deja. There is a defined difference between social isolation and loneliness. However, loneliness and isolation may be shaped by many factors, including culture, demographics, and the places where people, of course, live, work, learn, and play, the social determinants of health. So in May of, next slide, please. In May of 2023, the U.S. Surgeon General released an advisory that drew attention to the public health crisis of loneliness, isolation, and the lack of connection. Social connection, including its structure, function, and the quality of relationships with others, is very critical in, and I guess appreciated. It's an underappreciated factor in individual and population health. So I'll jump over to the next slide just to share with you guys a few statistics around social isolation and loneliness. So older adults, they are at an increased risk for loneliness and isolation because they're more likely to face factors such as living alone, the loss of family or friends, as well as chronic illnesses and diseases. So according to the CDC, 1 in 4 adults ages 65 and older are socially isolated. As the CDC also presented data that showed that the cost of loneliness it's very high. And it's high on the US economy in that it's estimated to cost $6.7 billion a year in Medicare costs. Okay, next slide, please. So there are risks, there are health risks indeed associated with loneliness and isolation. And so although these are kind of harder to measure precisely, I should say, there is strong evidence in research that shows that many adults aged 50 and older are socially isolated or lonely in ways that put their health at risk, which in turn bears the result of a big economic impact on society. Data the data in this slide was obtained from the Centers for Disease Control and Prevention. And again, because of time, I won't go through all of these, but they are a great reference point just to putting all of the disparities of loneliness in the older adult community into a greater perspective. Next slide, please. So these are the impacts of loneliness and social isolation on the older adult community. Loneliness and isolation, they, as I previously stated, can definitely exacerbate healthcare inequalities in older adults. Loneliness and isolation, they also pose a serious threat to mental and physical health, and they're linked to increased risk of chronic conditions such as dementia and heart disease and stroke, as well as depression, anxiety, and suicide, self-harm, addiction, type 2 diabetes, just to name a few. Social isolation resulting from living in disadvantaged neighborhoods that have fewer community amenities, disadvantaged neighborhoods that have reliable and accessible transportation and social support networks can also significantly impact loneliness and social isolation. And older adults who lack close relationships or family support or friends are at a higher risk. So factors such as marital status, family structure, and social connectedness within communities can all influence the availability of social support and impact loneliness levels. And then the last thing I'll say about that slide is that older adults from racial and ethnic minority groups, they may face unique challenges that contribute to loneliness, including discrimination, language barriers, cultural differences in social norms and systems of support, as well as disparities in access to healthcare and community resources. Marginalization and social inclusion, or I should say social exclusion, based on race, ethnicity, or immigrant status can exacerbate feelings of loneliness and isolation. Thank you, Deja, for the next slide. So what are some strategies that older adult professionals can put into place to advance equity for older adults in the delivery of services? So we have advocacy. Advocacy is essential. You want to advocate for policies and programs that promote equitable access to services for older adults, especially those from marginalized communities. This includes advocating for resources and for infrastructure and for improvements that will address disparities in service delivery. And then education and training. You want to provide education and training to other professionals in the field on issues of equity and inclusion, because this is a practical way of helping to raise awareness and build capacity for serving older adults from diverse backgrounds in an effective way. You want to enhance cultural competence by understanding and respecting the unique needs and preferences of older adults from different cultural, ethnic, and socioeconomic backgrounds. And this can involve learning learning about cultural practices, learning about traditions and languages to better serve diverse populations. You want to engage with older adults in their communities. Directly engaging with them in their communities helps you as a professional to understand their needs and preferences. And doing that can help to tailor services to be more responsive and inclusive. So this can involve collaborating with community organizations, or conducting surveys or gathering feedback from the individuals you work with. And then form partnerships. This is another great one. Form partnership with other organizations and stakeholders, as well as those committed to equity and social justice. Doing this can amplify efforts to advance equity in service delivery for older adults. Additionally, collaborative initiatives, they can leverage resources and expertise and create networks that can affect meaningful change for the older adult population. Next slide, please. So another strategy that's very important to reducing inequalities among older adults is to be informed of the importance of screenings and assessments. So more specifically, I should say healthcare screenings and assessments. These tools are very crucial for older adults for several reasons. These tools and assessments help with early detection of health conditions, preventative care. They help to manage chronic conditions. They are great for mental health monitoring, as well as for medication management. However, the disparity is that all older adults, they don't have access to these important and necessary screenings. And as a result, they have an inequality in healthcare access. So I'll move on to the next slide for sake of time. And get a head start. Get a head start. This is another way to practically reduce or address inequalities in service delivery. And for all these reasons here, and I won't go through all of them, getting a head start by researching, identifying, and applying for resources early for your client base or for the older adult individuals that you work with are essential. So it helps you to avoid making a rushed decision. The more informed you are about resources and services that are out there, and the earlier you apply for these opportunities, it helps you to really put into perspective how this particular service or resource will benefit that older adult. And it allows time for you to thoroughly research and to fairly evaluate and compare available resources. And it gives you a head start to adding individuals to wait lists. We know that older adult resources are very limited. From my purview, a lot of services that are out there, they come with the wait list. But if you get a head start on identifying and applying for these resources, then there's potential for getting a head start with being added to wait lists. And then, of course, it can help reduce stress related to the process of planning, life planning for the older adult that you are working with. And it also helps to release stress around barriers that you'll encounter along the way, because they are definitely going to come up. And then lastly, I will not go through all of these, but I always like to end with a few valuable resources that you may be able to use for your work with the older adult community. Next slide, please. So without reading them slide for slide, this one here is about SHIP. It'll help to give you information on Medicare. If you or the older adult you're working with needs to understand what it is, how it works, there are trained staff and volunteer counselors who are available in all counties in Baltimore City for one-on-one assistance and to provide community education. Likewise, there's Maryland Access Points. And this is a great resource for individuals with Medicaid who are seeking assistance with long-term services and supports. So if they're looking for resources or information on housing, transportation, senior centers, nutrition and meals, or even pharmacy assistance, Maryland Access Point is a great place to start. And then there's a program here that's called Public Assistance to Adults, also known as PAA. And this program pays for the cost of care and provides a personal needs allowance to lower income individuals or older adults who live in assisted living facilities that are licensed by the Maryland Department of Health. Next slide, please. Another essential resource here is the home and community-based waiver. This is one of those home and community-based waiver programs that I referred to in the previous slide when I was explaining how Medicaid is working to bridge the gap of inequalities. This is a great program that you can read more on this slide about and or online, and I put the link in the slide. Okay, you can read about it through this slide or online. And if there are older adults who you think could benefit from it based on the eligibility guidelines, go ahead and contact Maryland Access Point to have those individuals screened and or added to the wait list. And then the next resource I put here is behavioral health assisted living. This here is my baby. This is the program that I oversee here at Behavioral Health System Baltimore. This is a pilot program, a pilot assisted living program that is designed to provide services to older adults who have serious mental illness, as well as the need for assistance with activities of daily living. So here you can access all of the eligibility criteria, as well as how to submit a referral application if there is someone who you're interested in referring. And then last but not least, 988. This is a wonderful resource. I'm sure that plenty of you out there are familiar with it, but you can call or text 988 to connect a person in crisis to compassionate care and support. So these are all of my slides. Thank you guys so much for bearing with me through my technology challenges. I am not sure what they were all about, but I'm happy to have had the opportunity to get this information out there and to be invited to present on this platform.
All right, it is 3 o'clock. We'll go ahead and get started with our last session of the day. We've learned throughout the 2 days of training, many factors influence our theme of balance and optimal aging. This session, we'll consider its relationship with nutrition. Recognizing health status is influenced by a vast and interconnected set of determinants. Dr. Matthew Lee Smith, an associate professor at the School of Public Health at Texas A&M University, has devoted his career to creating synergistic partnerships and initiatives to encourage positive lifestyles and reduce rates of preventable morbidity and mortality. He has earned a national reputation as a falls expert and evaluator of evidence-based programs for older adults. His involvement in state, local, and national evaluation initiatives have been integral to fostering understanding about the reach, adoption, implementation, effectiveness, and maintenance of different evidence-based programs targeting key populations in a variety of community, school, workplace, and healthcare sectors. Dr. Smith's evaluation efforts have been funded by organizations including the National Institute of Health, Administration on Aging, National Council on Aging, Centers for Disease Control and Prevention, and Centers for Medicare and Medicaid Services. Today, Dr. Matthew Lee Smith will detail the relationship between malnutrition and the fall risk in older adults. The presentation will also provide valuable tools on identifying malnutrition risk, along with community-based older adults. Welcome to our conference, Dr. Smith.
Well, thank you so much, and I appreciate that warm welcome. Pleasure to be here with everybody all the way from Texas to really talk about and focus on a homegrown Maryland intervention called Stepping Up Your Nutrition. So it's a pleasure to be here, and especially with this group. And I'm hoping to give some practical information and some things that you all can use and hopefully learn a little bit more about in terms of things that are available in your state and can be beneficial to the older adults that you serve. So what I'm going to do is cover a couple different topics. First, of course, talking about the link between malnutrition and falls, because it is so important. But of course, as mentioned, I'm going to also just highlight some of the screeners and ways that we can identify the risk, and of course, how we can address that risk in one such way called Stepping Up Your Nutrition, which is a brief intervention that uses the ability to address malnutrition to prevent falls, so specifically for that purpose. And then I'll conclude by ever so briefly talking about some opportunities where you all can think about adopting SUIN in your own organizations and your own day-to-day practice with older adults, and how it leverages with certain other ongoing large grand scale national initiatives. So amazingly, Dr. Addison already spoke about falls, so I probably don't need to say anything more about it. But, you know, as we all know, it is a very important issue here in the United States, focusing and impacting on our older adult population. And not only is it predominant and affecting many older adults, once they fall, they're more likely to fall again. And when that does happen, many will obtain a very serious injury, maybe a fracture or some sort of traumatic brain injury, something, which then results in so many negative consequences. And we talk about the differences and challenges in terms of mobility, but also that loss of independence, potentially having to go into assisted living homes or outside and uprooted from their existing home environment. But naturally, and that is very expensive. We talk about over $50 billion attributed to falls just in direct costs, not even with all of the rehabilitation and caregiving and everything else associated. So we certainly know that's a huge problem. Now, I typically look at falls as this very complicated, multi-directional situation. Sometimes we look at the fall as the actual incident, the actual focal point, and we want to prevent that fall. But we also need to understand that the fall itself might be caused by many different things, but it might also be a symptom of many other things that are happening. So the fall itself can be seen as an outcome, but it can also be seen as a symptom or a sign of other things. And the problem becomes so many things influence the occurrence of a fall, such as sleep, medication, physical activity, nutrition, social isolation. All of these things can affect the happening or the occurrence of a fall. But after a person falls, then all of those things become disrupted. Their sleep becomes disrupted. Their physical activity and mobility becomes disrupted. Naturally, their home environment might need to change or be modified. The medications they're taking, if they now have to take other types of pain suppressants or other medications, it will all start to influence, and especially when we talk about nutrition. Poor nutrition can cause falls, which we were going to talk about, but the problem becomes that after a fall happens, it can disrupt a person's appetite and their overall nutritional intake. And so it becomes very important in the grand scheme that we understand the nutrition, the undernutrition of older adults, and how that can prevent falls, and certainly how it can prevent subsequent falls if they do occur. Now, when we talk about malnutrition, you know, we all think we know what malnutrition is, and I think we all do to some degree. So malnutrition is, of course, the lack of proper nutrition. And that could be caused by a variety of things. So not having enough food to eat, not eating enough of the right things, or being unable to use the food that you do eat, meaning our body does not process it and use it the way it's intended. So this can be a very complicated situation where it's not only about not having access to affordable foods, not having enough of the food that you can eat and that you can obtain, but also even if you do eat the food, that your body is not using it to its optimum ability to prevent disease or function properly in terms of all of our basic human functioning. And so when we think about malnutrition, sadly, about 50% of older Americans are considered to be malnourished. Now, remember, malnourishment can be the under or over nutrition. And we oftentimes only think when we talk about malnutrition that it's an individual who is completely frail and wasting, very skinny, very thin. But that's not always the case. We can also see many individuals that you wouldn't know they're malnourished, or even obesity can be considered malnourishment. So it's an imbalance of what the body needs versus what it's getting. And unfortunately, about 1 in 5 households is affected by malnutrition. And when they do these comparisons, we see that malnutrition is on the rise. Sadly, about 20 years ago, only about 11 individuals over 100,000 were impacted and died by malnutrition. But that is rising and is over doubled in just 20 years. So that means that more and more individuals are dying from malnutrition than ever before. And these statistics are pre-pandemic, and we know how disruptive the pandemic was. So we certainly can think that the newer statistics might even be worse than this. Now, when we think about those 50% of Americans who might be malnourished, realize that that differs depending on where these older adults are. In the community and community dwelling older adults, we might not readily see as much malnutrition. Only about 20 to 30% might be considered malnourished. But at the same time, when an individual is hospitalized, you can see that a higher proportion are malnourished. About 60% are deemed malnourished. And that's a problem in hospitalization settings because those individuals are they have twice as long hospital stays, and they're 3 times more likely to die in the hospital. So malnourishment has a big ramification. It's a major contributor to hospitalizations, but if a person is malnourished in a hospital setting, it can become very detrimental and costly. It's estimated that almost $16 billion are spent on malnutrition for older adults annually. And that's just malnutrition related diseases, not everything else that goes along with it, especially falls, which we also know are very costly. So one thing that we often want to make sure is that, we talk about malnutrition and certainly we talk about the social determinants of health, but we need to better understand the linkage between malnutrition and food insecurity. Now, these are distinct topics, but they are highly, highly related to one another. So with that said, we certainly need to better understand malnutrition is that deficiency or excess of nutritional intake. Again, it can be that you're not getting enough, or it could be that you're getting too much. But it's an imbalance of the essential nutrients that you need to function optimally, to recuperate, to fight disease, to process food, to create, insulin and hormones and all of the other things that your body needs to be able to function, which we do know changes over time. In older adults, biology changes over time. So the nutrition and maintaining that positive nutrition is so important so that we can go ahead and prevent that infection and other types of illness. But the thing is that not everybody has access. Food insecurity is the condition where you don't have access to sufficient food or food of adequate quality or the food that's affordable. So it's either that we can't access it, we can't buy it, or if we do get to it, it's not quality. Oftentimes you think about food deserts and these other locations where maybe a convenience store is the only thing. There's no fresh fruits and vegetables. There's not fresh cut meats. It's a lot of processed foods, a lot of prepackaged and shelf foods. Well, again, that is about the malnutrition that you would get by eating some of those foods, but not necessarily the access to the foods. So it's this dynamic interplay between being able to get to the right foods, be able to obtain those foods, be able to process the foods once you eat the foods, but of course, eat the right foods for the optimum nutritional intake and those essential nutrients that you need. Now, when we think beyond that, we need to think a little more closely, but why is malnutrition so related to falls? And one of the main reasons is that malnutrition really, those older adults who are undernourished or malnourished can become very frail. Unfortunately, these individuals can start to have different types of deficiencies in the essential micronutrients that they need. And the ones that we oftentimes think about are calcium. So if we don't have enough calcium, we start to see that the bones start to become a little more brittle, and therefore osteoporosis or osteoarthritis might set in. Now, with that said, we also know vitamin D, and vitamin D is a great way to prevent falls because it actually stabilizes and prevents against too much sway. And when sway happens too much with gait, we see that individuals fall. So these are two micronutrients that we definitely focus on, but that's not all. During the aging process, we also lose muscle mass and muscle strength. And that helps to also reduce our bone density. And so when we think about the muscle mass loss and we think about our density of bone decreasing, we can understand that that makes us a bit more susceptible to not necessarily be as physically active and to not be able to perform our activities of daily living. Well, that makes us more sedentary. And the more sedentary we are, the more likely we are to avoid certain activities. And then when we get up and we do certain activities, unfortunately, they're less familiar to us. Our bones, our muscles, our joints, we might have atrophied. We don't have as much flexibility or strength or balance. And then we're more susceptible to fall. So unfortunately, individuals who are malnourished, they can also become dehydrated. They get fatigued, they get dizzy. But with that muscle mass, with that bone density lost, they can then, of course, have so many more risk factors for falls for very simple things that used to be very commonplace, things they would do all the time. Now, if you can see in this image, this compares the muscle mass of a 40-year-old leg to a 70-year-old leg. And what's interesting here is that when you look at the gray, you can see that the legs are pretty much the same size. But what this is illustrating is the reduction in muscle mass. And so even though the leg doesn't look smaller at age 70, the composition of the leg is smaller or is different, meaning that there's less muscle, there's maybe less dense bone, and therefore, again, we're reducing all of the strength and the balance and things that we need. So this is something that hides in plain sight. We don't always see, unfortunately, these deficiencies. And so we need to be better aware of them. And sadly, based on malnutrition, if a fall does occur, sadly, that increases the risk for malnourished individuals of fracture. And it also then can, really delay the different types of, like I said before, the different types of, routine behaviors in terms of them eating, physical activity, sleep, taking medications. We all know when you take medications, that in itself can be a risk factor. But if you fall, all of a sudden, all of your regimens are relatively disrupted. And then, of course, that actually increases the odds of recurrent falls. So there's a lot of really, really highly associated risk factors between malnutrition and falls. But, many times when we're trying to identify malnutrition, we think that we can identify it. And a lot of times we ask individuals to tell us about their eating habits, about their appetite. But oftentimes, what is the most predominant signs and symptoms are things we observe, things we can see. It's great to ask questions, and we'll talk about that here in a moment, but we certainly can observe many different things. So, for example, we start talking about unplanned weight loss. That is certainly a warning sign of malnutrition. And oftentimes it's not that we're weighing the individuals, but instead you can start to see the clothes start to fit different, their belts start to fit different, their dentures might start to fit different. So we need to better understand and observe when this is occurring. A loss of appetite, that actually can change a lot with other chronic conditions, the medications they may take, and also just sometimes biologically parts of aging, the appetite might change. But what we see is that these individuals start to eat smaller amounts of food. And if you're eating smaller amounts of food, if you're not having that appetite, then you might not be getting the substantial amount of nutrients and food that you need to be able to best function properly. These individuals might also feel weak or tired. They might start to feel cold and have pale skin. But also, in addition to that, they might have edema. They might start to have swelling or fluid accumulation, typically in the ankles and the legs, which again is just indicative of them not necessarily being able to process the fluid intake, the different nutrient intake, and it might also be a symptom of some of the other cardiovascular type processes in the body. So we really do need to watch for the the edema that might occur. I already mentioned about the muscle loss and weakness, but also individuals who are malnourished, unfortunately, tend to get sick more often. They don't recover as quickly. If they do get a wound, they don't often heal as quickly. And so that's very challenging for us to be able to identify and to treat. And that's why we need proper nutrition. But also, we know that these individuals might have more mental confusion, poor concentration. They might have some poor judgment that comes with it because they're not getting enough nutrition to be able to function properly cognitively. And that can actually contribute to falls, as many of these were. So what we like to do is also talk about the real facts of it all. I mean, there's some big take-home messages, and that is, regardless of who the older adult is, malnourishment can happen, and it does happen. And it's not always so extremely visible. You can't just look at an individual and say, you are malnourished. Individuals are different sizes. Individuals have different eating patterns. They come from different backgrounds and origins and races and ethnicities and geographies, all of the above. And the thing about it is that we just need to better understand that even if we look at an individual and say, yeah, they're probably doing okay, that doesn't mean they are fully, completely nourished. They might be malnourished. And so that's why we need to dig a little deeper. We need to be able to assess, and we need to link them to resources and programs. A common misconception is that if the older adult just eats more, they won't be malnourished. And that's not true. They have to eat the right foods, the right balance of foods, and also not an excess of foods. So we'll talk a little bit about that. And the thing about malnourishment is that it is very complex. It's not just about the older adult and who they are biologically. It's also a lot in terms of behavior in what they do, but it's also the social structure that they have in terms of social supports, the ability to interact with other individuals, as well as organizations and services, and of course the environmental factors of where they actually are in the built environment, whether they can get places, whether they can safely access things, whether the food is present in their area. So it's that balance between malnutrition and its meeting of social food insecurity. And because so many of these factors are complicated, I just wanted to raise a few to you. These are some of the causes and effects of malnutrition. So, as we mentioned, chronic conditions are certainly one of the aspects of malnutrition. And not only can they cause malnutrition, especially because of the medications that an individual takes, the side effects that they experience, it might decrease their appetite. But in addition to that, malnutrition can create some certain chronic conditions that start to occur that the older adult wouldn't have had if they were properly nourished. So we know that a lot of individuals are on restricted diets, but they also might have oral challenges or dental challenges. So the dental health, inability to chew, inability to swallow, coughing and choking while eating, these can actually deter individuals from eating and challenge them to eat all the foods they want. Also, they might not be able to eat certain foods that have certain, certain types of nutrients, but at the same time, based on that, they might actually avoid those foods and therefore cause a deficit because they physically can't eat them. We know that older adults, and all of us actually, our taste buds change over time. So foods might not taste as great, and now all of a sudden your preferences start to change. Well, that means that you might shy away from or maybe lean into certain types of foods and nutrients, but that can certainly change the way that individuals eat and their patterns. I love that Rachell was talking about social isolation, because we know social isolation and loneliness are very important, whether an individual lives alone, whether they have the support, whether they can physically get to places, the social determinants of health in terms of income and food insecurity, which we talked about, but naturally all of these other aspects in terms of sensory impairments, mobility impairments, cognitive impairments. We know all of these things to be very important in terms of falls. So in addition to just observing older adults and having them come into our organization and our interactions with them, we definitely take a look and try to figure out, how can we ask questions? How can we learn more about malnutrition? How do we identify it? How do we justify that we have identified it well? And then how do we use that scoring, that risk, to be able to link them to programs and services? So here are 4 different screeners for malnutrition. I'm hoping that you are familiar with them. If you are not, I'll give a little high level. But the Screen 14, this is a community-based screener, oftentimes used in communities. And it's great because it can be very easily and quickly administered. It's only 10 items long. And what it does is identify the potential risk for malnutrition. Now, when you get those, 14 items, I think I said 10, but when you have those 14 items, you then can do a very quick scoring and immediately get a stoplight of risk from low, moderate to high nutritional risk. So with that said, this is a wonderful screener, very easy, very common language to be able to administer to older adults you work with. Most commonly across states is the NSI Determine, the Nutrition Screening Initiative, and it's Determine. And if you ask me to tell you what the Determine stands for right now, I probably won't be able to. But at the same time, this is a checklist based on some warning signs, and it's only 10 items. And it also has very easy scoring that puts you into low, moderate, and high nutritional risk. This is used across many different states, and it's required for a lot of food services in a lot of states. So this is probably the most commonly used nutrition screening we have. The MNA, the Mini Nutrition Assessment, is only 6 items. And again, it can go ahead and identify those individuals who are at normal nutritional risk relative to potential risk for malnutrition versus those who are actually deemed to be malnourished. So it has specific cut points that you can do the math in real time and find out. The MST, the malnutrition screening tool, is really, really short. It's only 3 items. And then based on the responses, you can just have a yes or no, a not at risk or an at risk score. And oftentimes the MST is used because it is so brief. So now if we can ask these types of questions, we work them into our intake, we work them into our service eligibility activities, we can identify risk, we can classify these individuals, and we can start to determine what kinds of resources and services, possible programs they can get. The reason I chose to show these 4 is because they're easily scored and you can very easily see, almost on a stoplight, high, medium, and low risk. In addition to that, the dynamometer can be used to show hand grip strength. And hand grip strength basically is a great indicator of not only malnutrition risk, but fall risk. And hand grip strength has been a link to fall related risk. And this is something that we oftentimes use in malnutrition. One of the reasons why hand grip strength is focused on is mainly because if you think about opening cans, opening jars, certain types of things that you would have to do to best meet your own needs, that hand grip strength is actually a strong indicator of being able to feed oneself or access food, but it's also a great way of just determining muscle strength, muscle mass, etc. So just in case you haven't seen, this is on the left-hand side, the NSI, that determine, and you can see it's a very quick 10 items. You ask those items that are in that purple square, and based on their responses, if they say yes, you sum up those numbers right there, and then you can know whether they're in that low, moderate, or high risk for nutrition. Really simple. The other one I decided to show is the MST, and that is that 3 items. And all you have to do is ask these very simple items, and if they score over a certain number, then all of a sudden they're at risk. And you can do this very quickly. They're very easily embeddable. So I wanted to show you examples of those, but also the screen 14. And the screen 14, again, is great because if you're not in a hospital or assisted living facility or any kind of clinical setting, this is great for community-based individuals. And so this is the Seniors in the Community Risk Evaluation for Eating and Nutrition. And again, even though I'm not showing the actual items here, there is the scoring that just shows you in a stoplight that the person has no or low risk relative to moderate, relative to high. So there are some great tools, but what we try to do is keep them very simple because, you know, a lot of times we collect data, we collect information, we want to assess our older adults and our clients, but the problem is how do we figure out what their risk is in real time? How do we then make determinations of what to link them to, what to refer them to, and how best to follow up with them to see if that risk has changed over time? So I've selected some of these to show just because they are so easily administratable. So you can just hand those out. You can ask them in an interview setting. You can get that information quickly, but then you can score it quickly so that you can act quickly. But allow me to turn the sights onto, well, so then what do we link older adults who have nutritional risks to? And the thing about it is that there are many different evidence-based fall prevention programs, and they are readily available. They are all throughout the United States. Maryland does a wonderful job implementing fall prevention programs and other evidence-based programs like for chronic disease or physical activity. The problem really becomes that when we look at the fall prevention programs that are out there that are supported by different grants or the Title 3D funding, they don't necessarily focus or contain any information about nutrition. Now, we know that falls and nutrition are highly linked to each other. There's a lot of evidence showing that, but these fall prevention programs don't necessarily focus on nutrition. And so what we found is that session 0, so you have a program and you're going to offer a workshop. Well, what if you offered a brief workshop before the workshop starts? A session 0. It's not the first session of the fall prevention program. It's a session 0 that goes right before that program. And we could go ahead and give more information about nutrition, malnutrition, identify risk, and use that to link people to those evidence-based programs and even other services. And that's exactly what Stepping Up Your Nutrition is. This is a very versatile, very practical, brief intervention that you can use in many different ways. It can be that session 0 for an evidence-based program. It can be offered as a standalone. You can just offer it, no other program associated, or you can just learn the information and use it in your everyday interactions with older adults. Great information, very practical. And I'll talk a little bit about it. But this brief workshop, SUIN, it has 2 real goals to it. first, we want our older adults to understand the importance of balanced nutrition to prevent falls. And then we also need to help them identify the warning signs for poor nutrition. And if we can do those two things, and then we can make some linkages and referrals, we've done a great job. And remember, it's so brief and it's so quick that we can do this very quickly. Now, I told you this was homegrown, so naturally, I have to tell you a little bit about its history. So, Stepping Up Your Nutrition actually came from a great partnership between the Maryland Department of Aging, who worked with Abbott Nutrition to be able to identify an opportunity that the Maryland Living Well Center of Excellence was happy to take on. The Maryland Living Well Center of Excellence had already created very brief interventions in session zeros, like for hypertension, and has already had the experience. So when MDOA found out that Abbott Nutrition was interested, naturally, the Maryland Living Well Center of Excellence was the prime entity to be able to help create Stepping Up Your Nutrition. So they've already had the experience. They already understand how to deliver and implement evidence-based programming, how to recruit and retain older adults into different workshops. Phenomenal. And so in doing that, this beautiful collaboration was formed, which was able to go and create Stepping Up Your Nutrition, which has two primary focal points: increase protein, increase fluids throughout the entire day. That's really it. As we all know, nutrition is complicated. There are so many nuances of preference and what types of vitamins and minerals are we supposed to get, and what is it that we really need when we have certain chronic conditions. If we have diabetes versus we have cardiovascular versus we're on low sodium diets, there's so much complication and nuance when it comes to nutritional interventions. Therefore, what SUIN has done is really focused on the linkage to falls. And with falls, the primary risk factors being dehydration and muscle loss. So therefore, increasing protein and increasing fluids can address many of those problems directly related to falls, relatively universal despite whatever other chronic conditions an individual may have. Now, we understand within reason, certain individuals might not need to eat tons and tons and tons of red meat or drink tons and tons and tons of water. But within reason, these two concepts are phenomenal for preventing fall-related risk. So the main messages that the participants get, of course, they need to understand that their nutrition and muscle health are directly related to fall-related risk, and that by exercising and having more protein, they can keep and maintain strong muscles. The other thing beyond the content is more about them understanding that they can take action and they can work directly with the healthcare providers to reduce their fall-related risk through communication, through linkages, through referrals, but also that there are local resources in the community so that they can get the food and nutrition services that they need and are eligible for. And this takes a little bit of the ownership of the facilitators to identify those local resources in the community and be prepared to share them with the older adults. But again, this is very well constructed, very well manualized. The implementation manual, the facilitator manual, there's a training to train the facilitators to do this very brief intervention. And it's already won some national and international awards, which is amazing. But let me just say, this program was developed by an amazing team. And as you can see, some of the credentials: registered and licensed dietitians and nutritionists were part of this. And that's what it came down to, was being able to identify the core elements of how to prevent falls and what to do to make it a universal program. So in so many ways, this amazing team came together, identified the content, identified the processes. Again, Leanne Eagle and Sue Lackenmeyer from the Maryland Living Well Center of Excellence, with the packaging and the ability to, host these programs and reach older adults in community settings, clinical settings, faith-based settings, all of the above, with their delivery infrastructure, just phenomenal. And of course, Judy Simon, who was with the Maryland Department of Aging at the time, is really a big nucleus of this as well. So this is that amazing team, all of those working together. I was just fortunate enough to be an evaluator. So the main messages are, of course, protein and hydration, and we try to keep it simple. And with that, this workshop, very brief, is only 2.5 hours long. One time, 2.5 hours long. And it can be led by 1 or 2 trained facilitators. Now, in that 2.5 hours, there's actually a protein tasting. You do a break and you introduce foods. Now, it's not that you just come in with, well, I'm from Texas, so let's just, with some brisket and some other things. That's not necessarily the point. The point is that you get individuals to try things that have protein that they might not have originally been introduced to. Things like hummus, things like nutritional supplements or drinks like Ensure or others. There's many different ways that you can introduce these tastings to say, hey, these are high protein foods, and these are things I can work into my daily routines to increase my protein beyond everything else I'm eating. So we talk about how nutrition affects falls, naturally muscle strength, and the key nutrients. Like I said, protein and fluid are the best. And with that, we also talk about identifying their nutritional risk in real time so that we know what next to refer them and link them to. If you can do that hand grip strength, that's phenomenal, but we also know that equipment can have a little cost to it. So not everybody has those, hand grip strength monitors, but at the same time, we also have them create action plans. And they create action plans, and those action plans can then be shared with their providers or anybody else so that they know exactly what the risk of the individual is and, of course, how to address it. The workshop size, we try to keep small, 10 to 15. And depending if you have 1 or 2 facilitators, that's enough to have a lot of personalized information. There's role playing that happens. There's a lot of brainstorming that happens. It's a very interactive 2.5 hours. And it's very low cost because the printing of the surveys, having the protein snack, which can be donated by partners, and the flip charts and the markers, it's just so simple and easy to do. You just need to have a room big enough to hold everybody. And if you want to see the breakdown, this is a little bit about what SUIN does in terms of just an order. You come in, you do a little bit of data collection, and then you jump into directly how nutrition affects falls and why nutrition is so important. And we really want the older adults to understand that linkage, but also to understand the linkage about their muscles. And again, because their muscles might reduce over time, over the years, we want to make sure that we can maintain them or grow them. So that's why we start focusing on physical activity, but we've really focused on protein consumption and why muscle is so important to fall prevention. We talk about the different nutrients. We talk about reading labels. We talk about the importance of hydration, how much protein is needed, whether the individual is healthy or sick, because I don't know if you all recognize when a healthy older adult, they might need certain amounts of protein, but if they get ill, if they get sick, they should eat more protein because it helps with recovery. So there are certain different aspects of this as well. So the different nutrients to know, again, that hand grip strength, not always happening. The break of a certain food or a protein, whatever you want to do. And it's great. I mean, you just see these older adults' eyes light up, I've never really eaten high protein bread. Like, who has high protein bread? Who really eats a whole bunch of hummus? People oftentimes don't think about beans and other types of, canned fish. There's so many different ways to get protein that people don't think about that are also shelf stable, delicious. Now, I don't know about the canned fish. It's always delicious, but yeah, but also some of those protein drinks. So there's just a lot of ways that we can just get them to try these, because so many other programs say, well, you need to try new foods, and then they send them home. Well, what if we try them in real time and provide them to them, but also show them where they can purchase them so that we know that it's not something that's unattainable. They get that nutrition risk score, and that's usually done through a role play that they can go and identify this. They can brainstorm about the different types of risks that this individual experiences and how they can better improve their health and their nutrition. And then they create reasonable and practical and realistic action plans. And they learn how to make them. They actually make them. And then if they consent, you can actually create a letter to their physician that includes their nutritional risk and their action plan so that they can share it with their healthcare team. Really quite phenomenal. Examples of different types of proteins. Now, these are all the different types of things. Like I said, edamame, tofu, protein bars, high protein oats, different types of seeds, even cottage cheese or frozen yogurts of different types, protein powders, the supplements. There's just so much out there that older adults don't always think of where they can boost their nutrition, their protein in real time. And there's a ton of different handouts that come. The older adult gets great resources. These are covered during class. This is an example, like I was talking about the amount of protein that a healthy older adult should eat by weight, in addition to if they are actually ill or have an injury. And then, of course, just the benefits of fluid. And we talk about so much of this. And it's brief, but it's so impactful. And of course, we did a study on this just to better understand a little bit about SUIN. And I'm just going to cover this ever so quickly because, here in Maryland, we were able to go ahead and study the delivery of SUIN across 12 counties through 60 different workshops. And we reached about 430 older adults. And what we really wanted to do was understand the malnutrition risk of these individuals and whether or not the intervention was capable of linking them to a fall prevention program. So now that they've learned about nutrition and the linkage to falls, can we get them in a fall prevention program now that they understand their own risk? There's an article that you can access at any time. But what I wanted to say was that out of these individuals, about 60% of them only attended Stepping Up Your Nutrition. But then what we have is about 40% after attending SUIN attended Stepping On, a fall prevention program. And the average time between those was about 20 days, which isn't bad. That means within about 3 weeks, this individual was able to learn a bit more, be accepting of being linked to a workshop, and then based on the availability of the workshop in their local area, get enrolled into a 7-week fall prevention program. Now, when we identified these individuals, when they came into SUIN, you can see from this stoplight on the right-hand side that 71% were at high malnutrition risk. Just when they first came to Stepping Up Your Nutrition. Half of them often or sometimes skip meals, and many of them were also a bit more food insecure. 20% had problems getting groceries, and 16% said that the groceries that they did get didn't last long enough, and they didn't have money to get more. So again, when I was talking about the relationship of food insecurity and malnutrition, it is very, very highly related. But there are different issues that we need to be able to overcome. Now, when we compared the nutrition when we compared these individuals by their risk scores, we wanted to see what the high risk individuals looked like. What about those who are high risk for malnutrition? And those high risk individuals were much more likely to be females. They ate meals less often with other people, so a little bit of socially isolated or independent. They had poorer appetites. The high-risk individuals skipped meals more often, and they also didn't have money to purchase more of those groceries when they didn't last. So it's exactly what you would think. Their self-reported risk for malnutrition on the screen 14 highly correlated with what we also saw elsewise of that food insecurity and that malnutrition risk. On average, those individuals with higher risk, they also had lower nutrition-related knowledge and confidence that they could control or improve their diet. But the good news is, after identifying all of those issues and understanding more about their own risk, after doing the 2.5 hours stepping up your nutrition brief intervention, those people at highest risk were the ones more likely to continue on and attend stepping on fall prevention workshops. So mission accomplished. Just a wonderful way of having this session 0 and brief intervention. And I think, just generally speaking, the true benefits of SUIN, we can identify malnutrition risk in real time because, unfortunately, because of the other evidence-based programs that exist and fall prevention programs that exist, sadly, we might not identify or recognize that these individuals have nutritional risk or are malnourished unless we dedicate that effort. So SUIN is a wonderful way to identify something that may otherwise not be detected. These individuals get to try new foods. And it's just wonderful that they get to try these foods, these nutritional supplements, and they, oh, that tastes better than I thought it would. It's just phenomenal. I love it. And they also get to make personalized action plans. Now, after the 2.5 hour intervention and brief intervention, the most important part to me is about that referral making. You can take the information that they've given and you can make referrals to providers. You can also link them to food banks or other community services that can address their food insecurity or other challenges of obtaining affordable and quality food. But also you can link them to other evidence-based programs. And there are many of them out there. Overall, this is a brief and low-cost intervention and opportunity that can, just be embedded into clinical settings, community settings, into faith-based organizations, residential facilities, senior centers, you name it, all throughout the Aging Services Network. Anywhere that you're offering workshops and that older adults naturally congregate, this is very easy to do. And I would be remiss if I did not say a little bit just about the opportunities that are forthcoming. And I'm not going to get into much detail on these, but SUIN is a unique brief intervention, but there's a lot of things happening across the United States that really kind of shows its relevance. And so one being that, the Older Americans Act is requiring malnutrition activities into state and AAA plans. So we already talk about, Title 3C, this might be eligible for in terms of malnutrition identification, prevention, support. We talk about Title 3B, which actually can cover things like, screening older adults for falls or malnutrition or other health risks. Now, Title 3D funds don't currently cover SUIN because it's not considered an evidence-based program, but it can still be that session 0. It can still be linked to them, and it can still be given in conjunction right alongside those evidence-based programs that Title 3D will fund. In addition to that, the 2023 White House Summit on Food as Medicine, and also the year previous to that, the Congress on Hunger, Nutrition, and Health, they're identifying these needs and opportunities to address malnutrition, address food insecurity, and also, again, recognizing falls as one of the outcomes or contributors to malnutrition. So there's a lot of recognition. I would say here on number 3, the home and community-based services, there's a quality measure set that has a lot of different partnerships across entities like, CMS and, CMS and, just a ton, like the National Core Indicators and all of the other different organizations like Advancing States. I mean, there's all of these different partnerships that are existing that are basically saying, well, we can identify quality sets of measures so that we can better understand how to give home and community-based services. So we will see how those malnutrition fits into that. And of course, stepping up your nutrition or anything related to better nutrition for older adults fits into those plans. And then CMS also came out with their global malnutrition composite score. And it's about reimbursement. And that's kind of a process. And that's in more of, can you screen for malnutrition? Can you assess for it? And then can you document what happened and create a care plan? And that's a lot of what happened. So we just see a lot of opportunities to fit this in because it really does have a lot of application, but there's so much more beyond that. Now, with that said, I would like to go ahead and highlight that if you want to know anything more about stepping up your nutrition, contact these two wonderful humans in your local area. Leanne Eagle and Sue Lackenmeyer, again, the creators, the founders, the brains and brawn behind stepping up your nutrition. Just tremendous. And it is in your state and it is available. And there's a great group of leaders that have already been trained. So this is something that's very applicable, something that's very plausible. I'm just going to leave this up for a second, but these will be in the slides that are shared with you. And with that, because I want to leave a little time for question answer, and I can only answer what I can because I'm not a registered dietitian or nutritionist, that is also my information.
Outstanding, Dr. Smith. We love that presentation. I do have a few questions that I think we can squeeze in before the end of our conference if you're game.
I will do my best.
So you had mentioned earlier in the presentation a bunch of nutritional screening tools, and someone is asking where they can find those best.
Oh, wonderful. So those screening tools are easily searchable. If you just type that into a very simple search engine, Google, etc., they will come up. The PDFs will come up. Those are the most common. The Screen 2 or Screen 14 is one that in the slides, have a link to where you can find it. That is available on their website. So if you look for Screen 14, you'll be able to find it. I'm not sure how openly available that is for common practice, but it is certainly online. So I can either try to find the National Council on Aging also compiles screening tools for nutrition and other risks like falls. And so National Council on Aging also has some of those all in one place. But truly, these are very common and they are highly accessible and they're being used by state and local agencies. So it's all over the internet.
Excellent. The next question I have is, do you endorse home delivered meal programs? Do you consider them nutritionally sound?
Oh, absolutely. Personally, I find that if individuals cannot, shop or obtain food themselves, if they cannot cook for themselves, if they cannot go to congregate meal settings, home delivered meals are phenomenal. And medically tailored meals and home delivered meals, shelf stable meals, all of the above. As long as the nutrition is provided and that individual is getting the nutrition they need, I certainly believe that's exactly what's there. Like that's it. We're on the right path.
Great.
It's when
Emily,
individuals can't get the service that it really starts to become a problem. So there's a lot in terms of eligibility and also that service being available in their local area.
Emily is wondering if you're seeing a prevalence of dementia and malnutrition being a connection, I guess.
Yeah, so there's a really interesting thing. So I do a lot of Alzheimer's and dementia care work as well, and this is kind of you know, there's a couple different things where naturally when we start to see dehydration occurring, it mimics dementia related symptomatology. So sometimes an individual might be dehydrated, but people think that they're having, dementia like episodes or symptoms. And it's that confusion, poor concentration, etc. So a lot of times by increasing the hydration, which is malnutrition, but by, increasing that hydration, you might actually be able to see whether or not those are really cognitive symptoms. Now, the other thing is for individuals who do have dementia, they may not be able to regulate their own eating schedule. They may forget to eat, they might have less of an appetite, and therefore they can be very malnourished. And then that malnourishment can certainly exacerbate the symptomatology of the dementia. But inadvertent to that, opposite, some individuals living with dementia actually don't remember their schedules and will compulsively eat. Or if food is presented to them, they know that there's a social cue they should be eating. And therefore, there have been many different times, especially with wandering and pacing and other types of repetitive behaviors, that individuals living with cognitive impairment will end up eating 4 or 5 breakfasts. I'll eat breakfast, go to sleep, take a nap, wake up. Well, when I wake up, what do I typically do? Eat breakfast. And they're not necessarily being regulated enough. So that's overconsumption. There's a lot that goes into that.
That is my last question that I have. Dr. Smith, I can't tell you how valuable this information is and very insightful for our case managers in our region. Thank you for sharing your time and knowledge.
My pleasure. And I will stop sharing my screen.
All right, in closing, I'd like to remind you to complete your evaluation form since it correlates to attendance, which will pop up. Currently, it's in your chat. There's a link you can travel with. I hope each of you have had an enjoyable day and are leaving with tools to support your clients, members, and patients in matters of balance for optimal aging. Once again, I want to thank our incredible list of speakers for being a part of this event, and also my incredible team at the Communications Office here at the Department of Aging in helping us to be able to present this conference. Baltimore County thanks you for joining our conference, and we are strengthening lives of older adults we serve through resources. Please remember to mark your calendars for the Power of Age Expo happening on Wednesday, October 30th at the Timonium Fairgrounds to gather resources and/or connect your network with the largest event of its kind in the region for older adults. Once again, have a wonderful evening, and thank you for joining us.